let's proceed to other major blood group systems. So, as you can see here, merong table, okay, taken from Henry na textbook. Ayan. So, kung mapapansin niyo ano ba yung mga kailangang aralin dyan? Guys, actually, ito na yung summary nung ile-lecture natin. Mainly yung kanilang symbol, the number, gene, the chromosome, and the gene product name. So, guys, dito sa table na to, ang pinaka-importante lang naman dito sa part ng table na to, yung gusto kong aralin ninyo is yung gene and the gene product name. So guys, alam ko pinatanda ko lang sa inyo yung N-acetyl galactosaminotransferase na idagdag lang tong alpha 1,3. Okay? So same lang 'yon. So lahat 'yan papag-aralan natin. Tapos na natin yung ABO pala and RH. So the rest of the blood group systems itatakal natin. Mainly mag-start tayo sa major blood group systems. So before we proceed with Lewis blood group system, I just want to highlight some of the important things na kailangan natin tandaan generally sa major blood group systems. So, sorry. So, guys, sa-summarize naman na dyan, I just want you to memorize lahat, tandaan yung gene and gene products, genes and gene products, okay? So we have here other blood group systems. We have here the major and your minor blood group system. So lahat yan importante, okay? So we have here your major blood group systems, Lewis, MNSS, PNPK, I, Kel, Duffy, Kid, Lutheran. So dito tayo magfo-focus ngayong week. Tatapusin natin ang major blood group system. And next week, we have also the minor blood group system, Sir Jego, Cartwright, XG, Siana, Dombrock, Colton, Landsteiner, Wiener, Chida Rogers, Jerbich, Cromer, Nops, Injan, at marami pang iba. Meron pa tayong high titer, low avidity, and basta marami pa sila, okay? So, but today, i-discuss natin si Lewis at si MNS. Pero yun nga, before tayo mag-proceed doon, discuss muna natin yung tawag dito, the general characteristics or yung mga kailangang tandaan generally sa blood group systems natin. Specifically, your major blood group systems. So we have here the functional roles of the blood group system. So ano nga ba yung mga functional roles ng blood group system natin? Naka-table na dito guys, so madali na lang aralin. So sino ba yung mga glycosyl transferases natin? When we talk about glycosyl transferases, anong ginagawa nila? They add up immunodominant sugar dun sa ating precursor chain to make an antigen. So alam natin na yung ABO blood group system natin, mainly yung ABH genes natin, mga to, ABH or ABO blood group system natin, they are glycosyl transferases, P1, PK, and Lewis, lahat yan glycosyl transferases. Next, we have also structural relationship to red blood cell. So bakit structural relationship to red blood cell? Meaning they are attached, meaning they share, tawag dito, function with our red blood cells. Mainly, we have here your MNS, Jego, and Jerbich. Okay, example nung MNS natin, kasi guys, yung MNS natin, they are located sa glycophorenes dun sa red blood cells. And important yun sa structure ng RBC natin. We have also transport proteins. Okay, yung RH, KID, Jego, Colton, and KX. Ano yung naalala nyo kay RH? Yung function ng ano natin, ng RH structure natin, mainly yung protein natin. They are important in the transport of, ano yung pinatanda ko sa inyo?
Ammonia and carbon.
Okay, ammonia and carbon dioxide. Very good. Okay, next. Yung KID naman natin, guys, important naman sila sa transport ng urea natin. And yung Colton naman natin, important naman sila sa transportation ng water. So yung tatlo mo papatanda ko, RH, KID, and Colton, including Jego, KX, they are transport proteins. We have also complement pathway molecules. Bakit ang tatlo dito, your Chido Rogers, Cromor, and NOPS? So, bakit sila important sa complement pathway? So, tandaan natin, start tayo kay Chido Rogers. Guys, yung Chido Rogers natin kasi, they are not located on the intrinsic red cell structure, but they are located on complement 4 or C4. Okay? Which becomes bound then to red cell for the plasma. Again, Chido Rogers natin nakikita sila sa complement 4 or C4 natin. What about Cromer? Ang Cromer naman kasi natin, hindi rin sila nakikita sa red cell. Yung Cromer natin, yung mga antigens niya nagre-reside or nakikita or located sa CD55 or what we call now your decay accelerating factor. As we all know, guys, yung decay accelerating factor natin, di ba, naalala ninyo, they are regulator in our complement pathway. Okay, so and finally, your NOPs naman, NOPs natin, they are located naman sa complement receptor 1. Ulitin ko, Chido Rogers complement 4, your Cromer sa CD55 or what we call your decay accelerating factor, and your NOPs, okay, saan sila located? Sa complement receptor 1. Huwag kakalimutan. We have also adhesion molecules, okay? Adhesion molecules natin are Lutheran, your XG, LW or Landsteiner Wiener, and Indian. And ito mas importante, guys, pa-mute muna tayo, microbial receptors. So, we have also microbial receptors, meaning some of your, the viruses and bacteria, guys, may receptor sa mga blood group antigens natin. Mainly under what blood groups? Your MNS, Duffy, P, Lewis, and Cromer. So start tayo kay MNS. Gusto ko nang i-discuss sa inyo na sa under MNS natin, my dear friends, we have what we call now glycophorin A and glycophorin B and glycophorin C. So, gusto ko lang paalala sa inyo na under MNS blood group system, ang MN antigen natin, they are located kasi sa glycophorin A. And yung big S and small s antigens natin, they are located sa glycophorin B. Meron pa isang glycophorin which is your glycophorin C. Okay? Pero walang, associated lang siya sa MNS natin, pero walang MNS antigen ang located doon. So, gusto ko lang paalala sa inyo na yung glycophorin A natin, actually, it is a receptor for E. coli. Anong E. coli? Yung mga pyelonephritogenic strains natin. Okay? Which causes now pyelonephritis. Okay? MNS. Again, E. coli. Okay, anong strain ng E. coli? Pyelonephritogenic strain. Saan sila, guys? Sa glycophorin A. And take notes, nabanggit ko kayo na sa inyo from glycophorin A, glycophorin B, and glycophorin C. Lahat itong tatlong ito naman na glycophorins, yung glycophorin A, glycophorin B, and glycophorin C, these are receptors for what parasite? Plasmodium falciparum. Okay, Plasmodium falciparum. Yung receptor, may receptor siya sa glycophorin A, B, and C. Again, kanino associated na blood group system? MNS blood group system. Okay? We have also Duffy. So alam kong aalala nyo to sa parasitology. Guys, di ba? Yung Duffy natin, your Duffy blood group system or yung FY natin na antigen, di ba? Guys, meron din siyang receptor for what Plasmodium species? Dalawa yan, Plasmodium vivax and Plasmodium knowlesi lang sa Duffy. Plasmodium vivax and Plasmodium knowlesi. Kay MNS, Plasmodium falciparum. We have also your P. Yung P naman natin na blood group system, guys, tandaan natin, marami kasi ang P natin. P in general, meron ding PK. Okay? So gusto ko lang tandaan ninyo, pasulat, yung P. P system, lahat ng antigens ng P. Okay? Receptor sila sa anong strain ng E. coli? UPEC. Naalala ba si UPEC? Uropathogenic E. coli. Again, lahat ng P antigens natin or lahat ng antigens of P blood group system may receptor kay UPEC or uropathogenic E. coli. What about, ano pa? Ano pang antigen ng P? May microbial receptor. Saan? Yung PK din natin. Ganito yung pagkasulat ng K, nasa taas yung K. Yung PK naman natin, guys, receptor naman siya sa dalawa. Dalawa, okay? Dalawang bacteria. Streptococcus suis and your enterohemorrhagic E. coli or your EHEC. Specifically, guys, kasi si EHEC, as we remember, guys, ano yung pinoproduce niya kasing toxin? Tawag doon is your Shiga toxin. Naalala niyo ba si Shiga toxin? Yes, Shiga toxin. Okay, si Shiga toxin kasi meron siyang receptor for PK antigen. Okay, again, Shiga toxin, guys, kanino lang ito makikita? Kay enterohemorrhagic E. coli. Ano na kasing kinukos ni enterohemorrhagic E. coli? Kinukos niya yung hemorrhagic colitis or ano yung itsura ng stool natin dyan? 'Di ba bloody with mucus, 'di ba? Kung naaalala ninyo. Okay. So, we have also, ano pa ba? Lewis. Okay, yung Lewis naman natin na blood group system, merong nag-iisang antigen si Lewis na may receptor for virus and bacteria. Sino kayang antigen yun? Si Lewis B. Okay? Lewis B. Kakaiba. Nag-iisang antigen ni Lewis na may receptor for virus and bacteria. Sino yung virus na to? Guys, alam ko may mycoviro kayo pero maririnig nyo to siguro sa latter part ng discussion nyo kay Ma'am Dong. This is called your Norwalk virus. Okay? This is called your Norwalk virus. While bacteria naman, mainly, sinong bacteria? Helicobacter pylori. Kung naalala nyo, anong kinukos na kasi ni Helicobacter pylori? Peptic ulcer. Okay, naalala ninyo? Helicobacter pylori ang tawag dito? Nagkukos ng peptic ulcer. Guys, ano na kasing biochemical test yung very distinct kay Helicobacter pylori? Urease, 'di ba? Urease positive ang Helicobacter pylori. Kung naalala niyo pa, 'di ba, yung punch natin, 'di ba? Yung punch natin na acronym diyan, lahat 'yan urease positive. Sino kasi yung P? Ureaplasma, Nocardia, Citrobacter, Helicobacter. Oh. Naalala, hoy, 'di ba si Helicobacter pylori pa yung may urea breath test, if you still remember. Okay, wala lang. Favorite ko kasi yung micro nun. Okay. So, I guess hindi nyo na naaalala. Anyway, so we have also, ayan, Cromer. Si Cromer din, guys, I want you to remember, pinaka-last, very important. Si Cromer naman natin, okay. Hello, guys, meron pa ba kayo dyan?
Yes, sir.
Yes, sir.
Yes, sir.
Okay.
Yes po, sir.
Si Cromer naman natin, guys. Okay, again, I'm sorry. Kung naalala ninyo, guys, saan na kasi sa located? Si Cromer, kakabanggit ko lang kanina dito. Guys, Cromer.
CD55.
CD55 or decay accelerating factor. Okay? Your CD55 or your decay accelerating factor. Guys, yung CD55 natin or your DAF or decay accelerating factor, these are receptors for the following microbes. Sino tong mga to? Una, uropathogenic E. coli. Uropathogenic and intestinal E. coli. Okay, uropathogenic and intestinal E. coli. Number 2, ecovirus. Eco. Guys, hindi ko makakalimutan si ecovirus kasi lumabas sa board exam namin to. Ano daw ibig sabihin ng eco? O pa-search, guys. May orphan to eh. Nakalimutan ko na kasi. Search nyo ako anong ibig sabihin ng eco. Bala yung lumabas sa quiz. Eco. Yan, lumabas sa board exam namin. Alam naman namin to noon, pero syempre medyo nakalimutan ko na. So, guys, try to research it para alam nyo na soon kapag siguro kay Ma'am Dong, sa mycoviro ninyo, papag-aralan nyo, ano kaya ibig sabihin ng echo? Okay? So, yon again, echo virus. And number 3, Coxsackie B virus. Coxsackie. Guys, dalawa kasi ang Coxsackie, A and B. Pero tatandaan, ano yung receptor natin for DAF, anong virus? Coxsackie, variant of Coxsackie, B virus. Okay? Guys, wait lang. Ayan. Hello guys, nandiyan pa ba kayo?
Yes, sir.
Okay. Okay naman.
Yes, sir.
Yes, diba? Bongga. Gagaling nyo talaga. Okay. Anong section to? A and B?
Yes po. Yes, sir.
Okay. Teka lang ha. Meron lang akong kailangang replyan. Okay, okay. Okay, 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 okay. Teka lang, teka lang. Okay. So we have also biological receptors, your Duffy, NOPS, and Injan. Okay. So, okay, naintindihan ba yung mga functional roles of the blood group system? So, summary lang yan nung itatakal natin for the next coming days. So, let's talk about dosage. So, na-discuss ko na rin sa inyo before yung dosage effect, di ba? So, ano ulit yung dosage natin? This is a phenomenon whereby an antibody reacts more strongly with red blood cells carrying a double dose homozygous inheritance of the appropriate gene than with a red blood cell carrying a single dose heterozygous, sorry for the spelling, inheritance of the appropriate gene of an antigen. So, guys, yun na kasi yung mga blood group systems natin na nag-exhibit ng dosage effect, guys.
RH.
Okay. RH, except the antigen. Okay, your KID, blood group system. Duffy, Lutheran.
and
Hi, ang galing-galing. Grabe naman, ang galing-galing nyo na. Sige nga, pa-discuss ngayon. Paano ulit yan? Hoy. Guys, paano ulit yon? Yung ating tawag dito? Hello? Aray, ang sakit sa tenga. Ano ba yun? May mahina yung internet sa inyo. Hello? Anyone from the group who can discuss to me yung dosage effect? Mag-example tayo si Duffy. Ako na lang. Sige. Guys, for example, Duffy, for example, discuss ko na sa inyo, ang white individuals versus mga Caucasians at mga African American or yung black natin na mga population. So, I just want to discuss to you na ang mga white people or yung mga Caucasian people, meron silang double dose. Sila yung may true double dose ng Duffy gene natin. Okay, may double dose sila. For example, ito. Meron silang true double dose ng FYA genes. Okay, FYA gene, FYA gene. Okay? Ang mga black people naman natin or yung mga African Americans natin, meron silang single dose ng FYA gene natin. Single dose lang kasi guys, yung isa na na-inherit nila is a silent gene, which is FY lang. So guys, kung mapapansin natin, okay guys, saan dito yung homozygous state? This is the homozygous state. Ito yung heterozygous state. Okay, so kung i-type natin sila or kung i-check natin yung kanilang phenotype, okay, ang white individual, ang kanyang phenotype therefore is FY A positive, B negative. Ibig sabihin, anong antigen ang meron siya? FYA. Si black individual naman, meron siyang, ano kanyang phenotype? Same, right? FYA positive, B negative. Okay? So meaning, guys, kung mapapansin niyo yung phenotypically, ayan, kung mapapansin niyo parehong-pareho ang kanilang phenotype. Pero dito na papasok yung dosage effect na sinasabi ko sa inyo. Sino kaya sa dalawa ang mas maraming DOFA or FYA antigen? Si white. Okay? Kasi meron
White,
siyang
sir.
okay, kasi meron siyang true double dose nung FYA gene natin. So, if we're going to test it serologically, magmi-mix tayo. Okay, ite-test natin yung dugo nitong white and black. Imi-mix natin siya with anti-F or DAFI A, FYA or DAFI A. Guys, sino kaya may stronger reaction? White or black individual? White. Okay? Okay, ito yung may 4 plus na reaction. Ito, 1 plus or 2 plus yung reaction. Again, ano yung conclusion natin or ano yung explanation dito? Why? Because white individuals or Caucasians exhibit now the true double dose of FYA. So meron siyang homozygous state for FYA, meaning mas marami siyang FYA or DOFA antigen. That's why the reaction with anti-FYA na antibody is very strong. Ang grading, 4 plus. Nagets? Yun yung ano ha, yun yung idea dito or yun yung ibig sabihin sa dosage. Naintindihan ba? Hello? Hala, tulog na si Ler.
Hello
Yes,
po,
sir.
sir.
Opo.
Yes!
Sir.
Oo. Okay pa kayo? Yes? Yes.
Yes.
Galing naman.
Ayos
Ano ba yan?
lang po.
Nakaka-stress naman kayo. Stressing na ba kayo? So, let's proceed. Optimal temperature, okay? Guys, when we talk about optimal temperature, pinag-uusapan natin dito yung mga antibodies ng mga blood group system natin. So, we have here 3 phases of reactivity. Okay? Three optimal temperature, okay? Of reactivity ng mga common antibodies. May tinatawag tayong room temperature or what we call blood banking na terminology, immediate spin phase. We have also 37 degrees Celsius incubation phase or 37 degrees Celsius phase. And yung antiglobulin phase or tinatawag din tong IAT phase or IAT phase or indirect antiglobulin test phase. So ngayon pa lang, gusto ko nang tandaan ninyo at i-memorize kung sino yung mga antibodies na nagre-react at room temperature immediate spin phase. Guys, lahat ng cold auto-antibodies, meaning antibodies reacting to your own antigen, lahat yan, they react at room temperature phase, including anti-I, age, and IH. Lahat yan, anti-M, N, P1, Lewis A, Lewis B, Lutheran A. Guys, wag malilito. Hindi ito antigens ha. Tandaan, antibodies ang pinag-uusapan. Antibodies. Baka kasi malito na kayo soon pag andun na tayo sa lahat ng blood group system. Diyos ko, Lewis A antigen. Diyos ko, pag reactivity ang pinag-uusapan, temperature, antibodies ang pinag-uusapan, ha? Huwag kayong malilito. Kasi ako din naman nag-aaral ako noon, medyo nalito-lito din ako noon kasi medyo magulo rin yung teacher namin magturo, ganyan. So parang kailangan mo talagang intindihin ng mabuti. And yun, and fast track din kami noon eh. So guys, intindihin nyo na mabuti. Medyo nakakalito talaga ang blood banking kasi ang daming letters, numbers, na kailangan tandaan. Next, ano pa, 37 degrees Celsius incubation. Lahat ng potent cold antibodies, meaning potent cold antibodies, guys, they can react at 37 degrees Celsius phase, okay? Especially if causing hemolysis. Ano pa? Your anti-D, anti-E, and your anti-K. Again, yung DE natin under RH blood group system and your big K is under KEL blood group system. And lahat ng nagre-react naman sa antiglobulin phase, lahat ng RH antibodies, K, Duffy, KID, SS, Lutheran B, and XGA. Kung mapapansin ninyo, Lutheran A, room temperature phase, Lutheran B, antiglobulin phase. Huwag malilito. Guys, pa-memorize na ngayon pa lang lahat ng to. So kung mapapansin natin, lahat ng nagre-react at room temperature phase, kung mapapansin ninyo, naalala ninyo doon sa introduction natin sa na lecture dati, 'di ba? Lahat ng mga IgM antibodies are cold reacting antibodies, if you still remember, 'di ba? And they are considered clinically insignificant. So guys, when we talk about clinically insignificant, hindi sila masyadong importante sa blood banking kasi hindi naman sila nagkakos ng hemolysis. And guys, itong pinakatandaan, your 37 degrees Celsius phase and antiglobulin phase, all antibodies reacting or very active at this phase are IgG in nature and they are all clinically significant. Okay? Okay. So, let's proceed. Let's proceed with effect of enzyme treatment. So guys, yung enzyme treatment kasi natin guys, ginagamit natin to, madidiscuss natin siya by the end of the topic dun sa immunohematologic procedures. Ang enzyme treatment kasi natin, ito, para maintindihan natin na, ang ginagamit natin na enzymes are proteolytic enzymes. They target protein molecules. They modify various blood group antigens and are useful in testing, especially in cases in which there are multiple antibodies present in a sample. So guys, kung titingnan nyo yung idea ng effect of enzyme treatment, guys, para daw mas ma-detect natin yung gusto lang natin na enzyme, ay na antibody, kailangan nating i-treat yung sample ng enzyme para mawala yung ibang antibodies kasi gusto lang natin i-detect yung specific antibody na yon. Okay? So ngayon pa lang, papatanda ko na sa inyo yung mga ginagamit natin na enzymes in detection and identification of blood group antibodies. Again guys, ang enzyme treatment hindi ginagamit sa blood group antigens, ginagamit siya sa blood group antibodies. Ayan, we have ficin, which are isolated from fig plants, papain, papaya, trypsin, stomach, bromelain from pineapple. Diba kung naaalala ninyo, tapos na ba kayo sa immunology, yung ano, kapag trinit daw natin ng papain, ganyan, yung immunoglobulin, paano siya mahahati, mga ganyan-ganyan, di ba? Okay. So enzyme treatment removes hydrophilic water-attracting glycoproteins from the membrane of RBCs, causing the membrane to become more hydrophobic, water-avoiding, which would allow red blood cells to come close together. So ngayon pa lang, gusto ko nang tandaan ninyo, lahat ng mga tawag dito, lahat ng mga blood group system na mag-i-increase yung activity nila, magdi-decrease activity nila at no effect at all. Sino ba yung mag-i-increase yung activity nila after enzyme treatment? So, sino to mga to? Pasulat naman, your RH, KID, Lewis, I, P, ABO, natin na blood group system. RH, KID, Lewis, I, P, and ABO. Tandaan, wag kakalimutan. Next, yung may decreased activity naman. Sino to? Your Lutheran. Ang pinaalala sa amin noon ni Sir Edwin, kasi decrease, di ba? Pag bumagsak, ludum. 'Di ba? Bumagsak, ludum. Yan daw. Ludum. Okay? Lutheran, Duffy, MN blood group system natin. MNS blood group system. Meron pa, XGN Cromer. Ludum XGCR. So yan, yung may decreased activity. And no effect at all. Dico, ito yung patandaan ko noon Dico carry or Dico carry. Parang ganyan. Parang wala daw siyang pakialam. So no effect. Sino to? Jego, Colton, Kel. Jego, Colton, Kel. Dico. Okay. Dito na tayo sa sources of substances for neutralization. So ano naman tong sources of substances for neutralization? So guys, ganito lang yan. Etong mga substances na to, itong nakikita nyo sa screen natin. Okay? Wait lang. Okay? Itong mga substances na to. Yan. Itong mga to. These are substances, okay, that inhibits the action of specific antibodies against the soluble antigens. So meaning, guys, si anti-P1 can be neutralized by hydatid cyst fluid, pigeon droppings, turtle dove's egg white. Pa-memorize. Anti-Lewis naman, ayan, plasma or serum. Anti-Chido Rogers naman, plasma or serum. Anti-SDA, okay, can be neutralized by urine, and anti-Big I, human breast milk. O, wag kakalimutan itong mga to, ha. Wag kakalimutan pa-memorize. Okay? Anti-P1, anti-Lewis, anti-Chido Rogers, or anti-Chido, anti-Rogers, anti-SDA, and anti-I. Ang Chido Rogers kasi natin, it's a one blood group system, pero separate yung Chido at Roger. Pag-usapan natin soon. Ang dami-dami na. Guys, pwede kayong kumuha ng pangalan ng anak nyo dito. Ang cute, diba? Chido, Roger. Ayan, sana all may anak. Oh, yan na tayo sa Lewis blood group system. Yes. So let's start with the first major blood group system. That's your Lewis blood group system. Okay, ISBT number 007. So etiology, saan ba galing? Named after the first antibody maker, which is reported by Morant. Again, guys, very important din yung history kung bakit pinangalan na Lewis. Bakit daw? Okay? Named after the first antibody maker, si Lewis. Okay? The Lewis blood group system, okay, is a unique in that it is believed to be only system that is not manufactured by red cell. So tatandaan natin yun na this is the only system daw na hindi manufactured by red cell. Okay? Lewis antigens kasi are not synthesized by RBCs and incorporated into the RBC membrane structure. So meaning, hindi natin siya nakikita sa red blood cell. Meaning, hindi natin siya nakikita sa surface ng RBC. Instead, Lewis antigens are manufactured by tissue cells and secreted therefore sa body fluids. So meaning guys, saan natin nakikita ang mga Lewis antigens? Sa secretions sa body fluids. Okay? So ulit-ulit dito, sabi, Lewis blood group antigens are not synthesized by RBCs. These antigens are made by tissue cells, secreted into body fluids, and plasma. And naa-absorb na lang daw sila sa RBC membrane. Naintindihan ba yon? Again, Lewis antigens natin, nakikita sila sa secretions, body fluids, or plasma. Kaya daw minsan nadedetect sila sa surface ng RBC natin kasi naa-absorb, dumidikit lang sila mismo dun sa RBC. Kaya minsan they are detected sa surface ng RBC. Nagigets? Sabi pa dito, because Lewis soluble antigens are manufactured by tissue cells, antigen production depends not only on the inheritance of Lewis genes but also on the inheritance of secretor gene. So, ibig sabihin guys, malaki ang factor ni gene natin or yung ating secretor gene. Siyempre guys, ang Lewis antigens, again, nakikita sa secretions, body fluids. Kaya, ayan, meron tayong secretor gene. There is also a genetic interaction that exists between Lewis and ABO genes because the amount of Lewis antigen detectable on the RBC is influenced by ABO genes inherited. So guys, kung mapapansin ninyo dito, very complex ang Lewis blood group system. Kasi ang Lewis or yung Lewis gene natin nag-i-interact with secretor gene at pwede ring mag-interact ang ABO genes. Kaya nga guys, kung mapapansin nyo later on, may mga phenotypes tayo na A, Lewis B. Meron din tayong phenotype na B, Lewis B. Mga ganyan-ganyan. Kasi guys, nakikisali ang ABO genes sa production ng Lewis antigen. Saan? Sa secretions. Naintindihan? Again, 3 genes ang nag-i-interact sa Lewis blood group system natin to make Lewis antigens, and these are Lewis genes, your secretor or SED gene, and your ABO genes. So paano ba? Okay, paano ba nangyayari? Paano ba yung inheritance ng Lewis natin? Similar to ABO genes, Lewis genes do not code for the production of Lewis antigens, but rather produce a specific glycosyltransferase called now your L-fucosyltransferase. These enzymes now, or enzyme now, adds L-fucos to the basic precursor substance. So kung babalikan natin ang ABO blood group system natin, yung sa biochemistry ng ABO antigens, guys, sinong kapareho ni Lewis gene? Anong gene?
O.
Anong O? May O gene ba tayo?
H.
Age. Okay, wag malilito ha. Again, yung age gene natin, kamukha niya si Lewis gene. Kasi guys, pareho sila ng glycosyltransferases, L-fucosyltransferase, and same immunodominant sugar added, L-fucose. Okay? So, nasa Lewis tayo, wag kakalimutan, wag malilito. So, the Lewis antigens result from the interaction of genes, your lead gene or your Lewis gene, and your SED gene or your secretor gene. So, ano bang kailangan tandaan natin? Guys, ang Lewis gene, okay, ang Lewis gene natin at ang SED gene, pareho sila ng kinocode na glycosyltransferase. Ano yung glycosyltransferase na to? Okay, L-fucosyltransferase, pareho. They code for what glycosyltransferase again? L-fucosyltransferase. Again, anong pinagkaiba? So pareho rin silang immunodominant sugar, di ba? Okay, doon muna tayo sa lead gene or Lewis gene muna tayo. Guys, wag malilito na sa Lewis gene tayo. Si Lewis gene codes for L-fucosyltransferase at anong mangyayari? Ngayon, si L-fucosyltransferase, i-add niya daw. It will add the immunodominant sugar, what? L-fucose. Saan? Saang part ng precursor chain natin? Sa subterminal, again, pasulat. I-add niya sa subterminal. N-acetylglucosamine. GLC na, sorry. N-acetylglucosamine, okay? Diyan yung i-add sa subterminal. While SED naman, okay, it codes for L-fucosyltransferase and i-add niya naman yung L-fucose saan? Sa terminal. Okay, very good. Terminal. Saan ulit? Saang terminal? Doon sa pinakagilid, no? 'Di ba? Terminal galactose. Okay, titingnan natin mamaya kung saan natin ina-add yung mga to, okay? So here, let's review. Again, guys, tanong, anong type ng precursor chain ang minomodify nila?
Type 1.
Type 1 or 2?
2.
Hoy!
1.
One, sir.
Kasi nasa secretions tayo. secretions tayo. Ang patatandaan ko kasi dito, wag kayo malilito secretion. Oh, 1. Okay? Hoy,
Yes, sir.
Yes,
sampal.
sir.
Oh, pag red blood cell naman, patatandaan ko noon, ganito. Pag sa red blood cell naman, divine? Yan, gawa-gawa na lang tayo, 'di ba? Hoy, kailangan nyo maging creative, sis. Hindi ko sinasabi ito sa inyo kasi gusto ko, as much as possible, kayo yung maging creative. Ha? Gumawa kayo ng mga ganito nyo, makakatulong tong mga to. Sinasabi ko sa inyo, makakatulong tong mga ganitong eme kasi ang dami-dami yung tatandaan. 'Di ba? Dami kayong tatandaan. Okay. Let's review the formation of ABH antigens in secretion. Sige nga, tandaan natin, naalala niyo pa ba yan? Let's review the formation of ABH antigens sa secretion. Again, your segin will code for what? Ano yung kasing code ni segin ulit na glycosyl transferase? Hoy, sige magtatawag ako, wait lang At dahil nakita kita, sino ba to? Kiefer Ortega. Kiefer? Kiefer? Hello?
Good evening, sir.
Hi, good evening. Kamusta ka dyan?
Okay lang, sir. Kumakain ho.
Ay, kumakain ka ngayon. Anong kinakain mo?
Pagkain ho, sir.
Ay, alam ko naman pagkain. Siyempre, delikado pag tao yan. Oh.
Di ba din lang naman, sir?
Grabe si Kiefer. Masyado ka namang hindi pa tayo nakakainom nito Anyway, sige. Let's discuss this. Okay, let's review yung ABH antigens natin sa secretions. Guys, wag malilito. Nasa ABH antigens tayo sa secretion. Balikan natin paano ba nabubuo ang mga ABH antigens natin sa secretions. Mainly yung age antigen muna natin. Okay. Segin now codes for the production of what glycosyl transferase, Mr. Kiefer? Oh, nawala siya.
Sir, saan ho ulit? Sir, nawala po.
Nawala ka kung ano-ano kasi kinakain mo. 'Di ba? O ulit, si Segin, i-code niya yung production ng anong glycosyl transferase. O, 'di ba? Sabi ko sa iyo
Sir, Tejin, sir po, di ba?
You need help? Sige, maghanap tayo ng iba. O, okay
Sige
lang
po,
yan.
sir.
Kumain ka muna. Respect natin yung food.
Sige
Okay?
po, sir.
Oo, respeto natin yung food. Sino kaya hindi kumakain dito? Let's call Vincent Domingo. Mr. Vincent? Hello?
Sir.
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 Okay lang? Sige, anong kinocode ni Segin na glycosyl transferase?
L-fucosyl transferase, sir.
Ay, ang galing mo naman. And then, therefore, i-add niyang immunodominant sugar.
L-fucose, sir.
Very good. Saan siya mag-a-add ng L-fucose?
Sa terminal galactose po ba, sir?
Ha?
Sa terminal galactose po.
Very good. Sige, isulat natin dito. Gayahin niyo ako. Si Segin, i-code niyo yung production ng L-fucosyl transferase. Ngayon, saan siya mag-a-add ulit? I-add niyo yung L-fucose na sugar saan? Sa terminal galactose. Dito. Okay? Okay ba? Hello. Guys, wag niyo akong gayahin. Kumpletuhin niyo. Mamaya L-fuc lang nilalagay niyo dyan ha. Kumpletuhin niyo. Kasi kayo ba naman magsulat using using itong ang hirap kaya. Next. Okay na gets ba? Terminal galactose. Tama? Nagigets ba?
Yes.
Hello? Ano naman ngayon meron? Pag nangyari to, anong meron na tayo? Meron na tayong Hello?
Age.
Antigen.
Antigen.
Saan?
Secretor.
Anong secretor? Secretions.
Secretion.
Nasa secretions. Okay?
Sean.
Secretions. Okay? Naging teacher niyo ba si Ma'am Rita Alactiao sa St. Louis? Ay, hindi niyo na pala siya kilala. Ayan, may age substance na tayo sa secretions. Okay? Let's discuss. Paano naman? Sige, discuss ulit natin. Paano kapag namana naman yung aging? Sige nga, Mr. Miss naman tayo. Okay? Nicolette Kalimuhayan. Nicolette? Hello? Hello? Hala. Nicolette? Nicolette? Wala kayo. Bakit hindi kayo nakikinig? Si Rainier. Rainier Rodriguez. Rainier? Asan ba si Rainier? Rainier? Hoy!
Hello, sir.
Rainier. Ikaw. Sige nga. Discuss mo to. Paano kapag na-inherit natin yung aging? Okay, what will happen? For example, meron tayong age sa secretions. Kapag na-inherit pa natin yung aging, ano mangyayari? Sige nga, discuss it to me.
Sir, mag-a-add yung
Dire-diretso ka sa add.
sa
Rainier. Rainier de la Cruz. De la Cruz ka, di ba? De la Cruz. Hala, nakalimutan na nila. Ano na? Hindi mo alam?
sir.
Nakakalimutan.
Sir, yung
Parang pumipiyok ka.
mag-add yung N-acetyl galactosamine transferase, sir.
Yung aging, iko-code niya yung production ng, tama ka.
Yes, sir.
Ayusin lang natin yung statement mo. Iko-code niya yung production ng what fucosyl transferase, your
N-acetyl galactosamine transferase, sir.
Okay, ito yung acronym niya, GALNAC. Again, wag malilito. Iba ang GALNAC sa GLC-NAC. Ang GLC-NAC, N-acetyl-glucosamine. Ang GALNAC, N-acetyl galactosamine transferase. Okay? Okay. And then, ano mangyayari? Assuming andito na yung L-fucose, di ba? For example,
Yes,
andito na yung L-fucose. Ano mangyayari? Hello?
Yes, it will code for
Hindi, it will add, itong N-acetyl galactosamine transferase natin, mag-a-add na siya ng immunodominant sugar na
N-acetyl galactosamine, sir.
Ano?
N-acetyl galactosamine, sir.
Oo. Saan? Dito ba?
Sa
Sa puso mo. Saan? Ito, 'di ba ito dito?
Yes, sir.
Okay. Dito na tayo mag-a-add nung N-acetyl galactosamine na Naiintindihan ba? Hoy, nagre-review lang tayo, Rainier, O Rainier, hindi ka pa tapos sa akin. Therefore, meron na tayong
Antigen, sir.
Saan? Ayun lang. Nadali na kung saan. Nasaan? Huy!
Sir, I forgot.
Asan ba siya? Anong I forgot? Kaka-discuss lang natin.
Sa terminal, sir?
Hoy! Hindi. Tatanong ko lang kung nasa secretions ba siya or RBC.
Ay, sa RBC, sir.
Anong RBC?
Ay, secretions.
Secretion, we're talking. Nasa senga tayo, mabebe, Ano ba yan? Okay lang yan. Feeling ko nalilito ka or baka kumakain ka ngayon ng lechon. Anyway, balik tayo dito, Rainier, kay Bging.
Yes.
Sige, discuss mo ulit to. Paano pag namana si Bging?
Sir, pag namana yung Bgin, sir, mag-add yung D-galactosamidyltransferase, sir.
Hindi nga mag-a-add. Si Bgene, iko-code niya yung production ng anong glycosyl transferase.
D-galactosamidyltransferase, sir.
Okay, and then, assume natin na meron yung L-fucose dito. Okay, tapos,
Magpo-form siya nung
tapos,
D-galactose dyan, sir.
Oo, i-add niya si D-galactosamidyltransferase. I-add niya yung D-galactose dito sa
sir.
pinakagilid. Ha? Okay, naintindihan mo na.
Yes, sir.
Ano na lang meron tayong ngayon? Meron ng formation ng
B-antigen sa secretion, sir.
Ay, ang galing-galing naman ni Rainier. Thank you, Rainier.
Yes, sir.
Okay. Okay na? Hoy! Diyos ko Lord, kayo ha, nagre-review lang tayo. Nasabi ko sa inyo, paano lang kapag ang dami na natin pinag-usapan na edi wala na. Okay, mag-aral. Huwag kakalimutan tong mga to. Kalimutan ng lahat, huwag lang tong mga to. Okay. Okay na ba, guys? Type 1, kung naintindihan ba yon? Type 1. Ayun lang. Walang nag-aano. Ayun. Ayos. Alright. Okay. Clear. Okay. So, tapos na tayo. Diniscuss ko lang ulit para wag tayong malito. Discuss naman natin ngayon, what is happening in Lewis. Sa Lewis naman natin, papag-usapan na natin ngayon si Legene or your Lewis gene. Again, sige nga, Miss Ira Machas. Ira Machas, pasagot nga ito. Hi, Ira.
Hi, sir.
Sex bomb, Ira. Kamusta ka naman? Musta naman yung sila Jopay and okay naman.
Okay naman.
Okay, sige. Halukayin mo lang yung ube, ha? Okay, sabi dito, Legene codes for the production. Sige nga, discuss sa akin.
Sir, Lewis gene codes for the production of L-fucosyl transferase.
Ay, ang
And
arte. Tapos?
Then they also add, sir, mag-a-add sila ng L-fucose sa subterminal wherein dun sa may N-acetylglucosamine po.
Okay, very good. Okay, again, Lewis gene, Lewis gene codes for the production of L-fucosyl transferase at i-add niya ngayon yung L-fucose na immunodominant sugar saan? Sa subterminal N-acetylglucosamine. Magkaiba kay Segene. Saan si Segene? Saan niya ina-add? Sa terminal, di ba? Tama? Si Segene
Yes, sir.
ina-add niya sa terminal galactose. Wag yung kakalimutan yon, okay? Mamaya may pinakita ko sa inyo mga picture, ewan ko na lang sa inyo. Okay? So, ba't ang gulo? Guys, magulo ba yung ganito nyo? Hindi naman. Maayos? Hello?
Maayos po.
Okay. Maayos. Okay? Ano naman ngayon? 'Di ba? Ano naman ngayon? 'Di ba? So, wait lang. Paano ba to? Guys, sa baba ba ng handout nyo may ganito? May dalawang ganito? Nandito siya, 'di ba? Tama ba?
Yes, sir.
Tapos meron pang
Yes,
isa dito.
sir.
Meron pang isa dito.
Yes,
Yes,
sir.
sir.
Okay, nagulo lang to. Okay. Okay. Sige, gets ko na. Teka lang guys. Ayusin ko lang Sige, wag na nating ayusin. Example na lang, ito na yon. Yung nasa handout nyo guys, for example, ito makinig kayo na mabuti. Ayan. Yan yon. Nasa Lewis gene tayo guys. Kunyari, ito yung nasa baba. Guys, hello?
Yes, sir.
Okay, nagigets. Hoy. Hoy!
Yes, sir.
Yes,
Yes, sir. Yes
sir.
po.
Yes,
Sorry guys,
sir.
hindi ako mapanatag kapag wala nag-yes sa akin. So yes lang kayo ng yes. Okay, si Louis Jean, for example. Ayan, inherited natin yung Louis Jean. Guys, so it will now code for the production of L-fucosyl transferase. Ngayon, si L-fucosyl transferase natin, mag-a-add therefore mag-a-add siya ng immune dominant sugar sa, ayan, dito ha, sa subterminal N-acetyl glucosamine. Naintindihan? Ayan, sa subterminal N-acetyl glucosamine. Okay, nagets ba? Ngayon, ano na mabubuo nating antigen? Hello? Guys, ano na mabubuo nating antigen, Miss Ira? Ira Bells, asan ka na?
Yes, sir.
Oo, ano na mabubuo nating antigen?
Sir, yung H gene po.
Hindi. Anong age gene?
Ah,
Antigen nga eh.
ano tawag dito?
Wala na tayo sa ABO ha. Nasa Lewis tayo. Eh di Lewis
Yung Lewis
antigen.
antigen po.
Anong
Opo.
Lewis antigen? A. O, wag kakalimutan. Kapag ganito lang yung reaction or parang ganito lang yung gene interaction, again, yan lang. Si Lewis lang ang gene na nag-interact. Okay, or nag-interact daw, na-involve, sorry. Again, anong antigen lang ang mabubuo? Lewis
Louis
A.
A. O, di ba? Gigil. Okay. Next. Parang umongo ako dun na. Okay. Ayan. Therefore, we have two enzymes, Se and Le, competing for the unmodified type 1 precursor chain. Ano ba to? Okay, who can discuss this enzyme war sa akin? Anyone? Sino yung nagta-type? Guys, sino makakapag-discuss sa akin nito? Hello? O, di ba tumahimik lahat? Ganyan tayo mga estudyante. Kapag nagtatawag si sir, tatahimik, no? O. Hello? Ano, Nay? Sige, magtatawag ako, ah. Tingnan ko nag-advance reading kayo. Si, let's call on. Denver. Denver?
Sir,
Hi,
bakit?
paano naman, pa-share naman sa akin yung thoughts mo about enzyme war. Kung may world war tayo, syempre may enzyme war sa Lewis. Sige nga, pa-share naman yung thoughts mo or nabasa mo regarding enzyme war.
Sir, wala pa akong nabasa dito kasi inaantay kong ikaw mag-lecture kasi mas madali no, Kwan.
Parang chika-chika lang tayo dito. Hindi mo alam. Ala. Huy.
Oo, sir,
Okay ka
hindi
lang,
ko
Denver.
talaga alam.
Okay. O, sino
Sorry,
nakakaalam? Hoy, plus 10. Oh. Sa quiz. O, seryoso ako dito. Hello? Kasi magtatawag ako, ah. Hindi kayo nagbabasa na porket hindi na ako nagpapaano, ah. Ay, hindi sila nagbabasa. Si Gwyneth. Gwyneth. Hello? Koinet? Koinet? Sige nga, si Jamil na lang. Jamil.
Sir.
Hi, Mr. Tejada.
Hello, sir.
Sige. Alam mo ba to? Sige nga, pa-discuss nga sa akin tong enzyme mark.
Sir, hindi ko alam pero try ko, sir.
Sige.
Joe.
Sige lang, sige lang. There's no harm in trying.
Sir, di ba dun sa Sejin tsaka Louis Jean, pareho nilang kinocode yung L-fucosyl transferase, sir.
Okay, therefore?
Therefore, yun sir, magagawan sila kung saan mapupunta yung L-fucosyl transferase. Either sa Sejin ba, either ba si Sejin or si Louis Jean yung magko-code. Ay, ano ba?
Sige nga, ano yung naaalala mo sa Sejin? Based
Yun, sir,
on, hindi, based sa population. So, marami bang tao worldwide ang may Sejin? Ilang percent ng population, sige nga, worldwide ang may Sejin?
Sir, di ko maalala pero feeling ko marami.
80, sir.
80%.
Maraming secretors, sir.
80%.
80% ang secretors. Naalala nyo ba?
Yes, sir.
So kung iisipin natin, okay, sa mundo ng Encantadia, mas malakas si Alena kesa kay Pirena. Ayan. Si Sejin, mas marami kesa kay Legin. Okay? Kasi, guys, kung alam natin, 80% ng population are secretors. Right? Okay. So, mas powerful talaga si Sejin. So, kokonti lang ang may Legin. Okay? Ano ba yan? Bakit ganito? Sige, discuss natin. So, dito muna tayo sa una. Discuss natin na. So, again, your Le and Sejins, guys, they compete for the unmodified type 1 precursor chain. So, let's say, for example, this is your type 1 precursor chain. So, for example, naman na natin si Lewis gene. Okay. Your Lewis gene, therefore, will code for the production of L-fucosyl transferase. Again, si L-fucosyl transferase natin, i-add or mag-a-add ng immunodominant sugar saan?
Subterminal.
Subterminal.
N-acetyl.
Saan?
Glucosamine.
N-acetyl-D-glucosamine.
Sorry, nawala ako. Saan, guys?
Subterminal
Okay,
N-acetyl.
dito. Tama?
Subterminal.
Hello, tama ba?
Opo.
Yes, sir.
Okay, very good. Very good. Very good. Dito siya mag-a-add. Again, ano yung pinatanda ko sa inyo? Therefore, anong mabubuong antigen?
Louis A.
Louis A.
Louis A. Si Lea
Louis A.
Salonga. Oh, divine. So meron na tayong Louis A antigen. Again, kapag ganito lang yung ganapan dito sa kaharian ng Berbanya, okay? Si Louis A antigen lang ang mabubuo. Okay, i-take note, pasulat ngayon din. Guys, small amount lang ng Louis A antigen, okay? Pasulat, small amount of Louis A antigen are made, okay? And therefore, these Louis A antigens are not detectable serologically. We can't detect them serologically. So if we test Louis A antigen with anti-Louis A, walang serological reaction at all. Kasi very small amount lang yung napoproduce na Louis A antigen. Again, Louis A antigen are not detected serologically. They can only be detected using elution technique and molecular tests. Again, serologically, hindi sila na-detect. Ano lang? Through elution and molecular studies. Okay, dito na tayo sa kabila. Si Sejin, very powerful. Ayan. Sige, clear muna natin. Naintindihan ba yon, guys?
Yes, sir.
Okay, balik tayo
Yes,
dito.
sir.
Si Sejin tayo, isa-isahin natin ha. Sejin. Si Sejin, sige, mabilisan na. Ako na lang ha. Si Sejin codes for the production of what enzyme? L-fucosyl transferase. Therefore, L-fucosyl transferase will add now the immunodominant sugar, what? L-fucose sa terminal galactose. Tama? Terminal na tayo, nasa C tayo. Kanina si Louis sa subterminal N-acetylglucosamine. Sejin tayo guys, therefore i-add niyo sa terminal galactose. Nalilito pa ba? Kaya? Kaya. Hello?
Kaya, sir.
Okay. Oh, therefore, meron na tayong sorry. Sorry, ano na meron? Meron na tayong age,
Age antigen, sir.
antigen or substance sa secretion. Okay? Meron tayong age substance or age antigen sa secretions. Ngayon, paano pag minodify pa ito ng Lewis gene? Uy, minodify pa daw siya ni Lewis gene. Okay? Minodify pa siya ni Lewis gene. Tuloy-tuloy yung interaction. Lewis gene will code for the production of what glycosyl transferase? L-fucosyl transferase. Okay, baba tayo. Ay, bumababa din siya. Okay, L-fucosyl. Ay, sulat ko ulit. Uy, struggle is real Le. Okay. L-fucosyl transferase. Okay? Ngayon, so assuming, okay? So assume natin guys, meron na dito sino nang meron dito kanina? Si? Hello?
L-fucose.
Meron na si L-fucose. Okay? Ngayon, kapag nag-interact ngayon si Lewis gene code yung production ng L-fucosyl transferase. Therefore, mag-a-add siya ng ano? L-fucose sa subterminal and acetylglucosamine. Nagigets? Oh.
Yes,
Ngayon,
sir.
sino naman na yung anak? Ano naman yung anak ngayon? O ano naman ngayon? Ano na yung mabubuong ano ngayon? Tawag dito antigen.
Louis B.
Louis B, sir.
Okay, Louis tandaan na. Louis B age. Oh, age. Guys, kasi nakabuo tayo kanina ng age substance dito. Tandaan, mahina si Lewis gene at hindi niya kayang i-modify lahat yung age substance kaya may natitira pa rin age. Nagigets? Hoy. Hoy.
Yes.
Yes, sir.
Okay,
Sir.
Or tinatawag din siya na age leb or Lewis B. Pareho lang yan. Leb age or age leb, pareho lang. Okay? Okay. Ang hirap pala nito. Kasi parang ang hirap nung mouse. Wala pa akong mouse, guys. Gamit ko tong, ang tawag dito, yung parang, ito, sakit sa daliri. Okay, so dalawa na yung alam natin. Kapag si Lewis gene lang, result, ano yung antigen? Lewis A antigen. Kapag si Lewis and secretor genes natin nag-interact, ano yung final product natin? Lewis B age or your age Lewis B. Naintindihan? Okay. Tuloy-tuloy tayo. Paliitin ko siya para mas ma-appreciate natin So, discuss naman natin paano kapag, for example, guys, ano pang genes ang nag-i-interact dito sa Lewis blood group system natin? Nakikisali? Yung nabanggit ko kanina. Ano pang gene?
Gene, sir.
Very good, very good. Your ABO gene. Sige, discuss natin. Ano ko ba ito anuhin? Guys, marunong ba kayo kung paano ko siya papa-anuhin hanggang baba? Hindi, no? Kailangan ko na lang siya paliitin, no? Hello? Anybody home? Ayan, ganyan na lang. Ayan. Nagigets? Nakikita naman ba? Okay.
Yes, sir.
Okay. So this is your for example, tapos na tayo dito. Naman natin ng aging. Okay, si aging. Aging natin naman na again, ano na kasi ulit yung ano natin, yung L-fucosyl transferase natin dito, your N-acetyl
Yeah.
galactosaminil transferase. Naalala? Ngayon, i-add nyo yung anong
N-acetyl
ano?
galactosamine.
Okay. Guys, ganito lang yan na para huwag kayo malito. Di ba? Ito yung basis natin. Di ba may L-fucos na dito? Hello?
Yes, sir.
Huwag tayong
Yes,
malito ha.
sir.
Fina-follow lang natin yung formula. So guys, di ba tama? Gagawa muna tayo ng age bago makisali si A at B gene. Tama?
Yes.
Tama? Di ba? Kailangan may
Yes,
age
sir.
muna tayo bago makisali si A and B. Okay. So, assume natin na meron na dito si L-fucose, okay? Meron na dito si L-fucose, guys. Ngayon, saan ma-add yung immunodominant sugar ni A gene? Guys, dito sa pinaka-gilid, di ba? Naalala nyo pa ba? Okay. Guys, ano yung ma-add na immunodominant sugar dito? N-acetyl galactosamine. Naalala? Hello? Naalala?
Yes, sir.
Okay, therefore, anong mangyayari dito? Meron na tayong A antigen. Saan?
Secretions.
Pwede ko rin bang sabihin, meron na tayong soluble A antigen. Pwede ko bang sabihin yon?
Yes, sir.
Yes.
Yes,
sir.
soluble. Again, antigens sa secretions are considered soluble. Pwede siyang tawaging soluble A antigen. Huwag malilito. Next, what about pag B gene naman yung nag-interact? Again, B gene will now code for what? D-galactosaminil transferase. Okay? Ngayon, assume natin, again, katuloy lang nito, meron ng L-fucose dito. Okay, mag-a-add na tayo ngayon ng immunodominant sugar dito sa pinakagilid na D-galactose. Si D-galactose, guys, ito yung immunodominant sugar ni B. Therefore, ano guys, ano nang meron tayo? Soluble B antigen or B antigen in secretions. Naiintindihan ba?
Yes, sir.
Yes, sir.
Okay. Sige, baba tayo. Clear ko na to ha. Guys, i-follow nyo ha. Pa-follow ako. Pa-follow. Sunod-sunod kasi to. Okay, baba tayo. Therefore, paano naman ngayon? So, meron na tayong, okay, so, sorry. So, meron na tayong A antigen sa secretions and B antigen on secretions. Ngayon, nag-interact pa ngayon si Lewis gene natin. Okay? Ngayon, nakisali na naman si Lewis gene natin katuloy nung A gene. Si A gene, okay, nagkaroon tayo ng A. Dito muna tayo ha. Itong arrow muna na to. Huwag malilito. Nandito tayo sa side na to. A gene, nag-interact si A gene, may A soluble antigen sa secretions. Ngayon, nag-interact si Lewis. Ano mangyayari? Iko-code niya yung production again ng L-fucosyl transferase. Again, tama. Meron na tayong L-fucose dito, di ba? Sa terminal galactose. Tama? Ano pang meron? Di ba meron na tayong N-acetyl galactosamine dito, di ba? Hello, nagigets nyo
Yes,
ba
sir.
ako?
Yes po.
Katuloy lang to ha. Okay, ngayon, doon na tayo. Si Lewis gene. Guys, inad niya si kinode niya yung production ng L-fucosyl transferase. Ngayon, mag-a-add ng immunodominant sugar saan? Sa dito, sa subterminal N-acetyl glucosamine. Nagigets ba? Hello?
Yes, sir.
Yes,
Therefore,
sir.
ano nang meron? Ano nang meron?
Sir, magkakaroon siya ng A Louis B antigen.
Very good. Meron na tayong A Lewis B antigen. Naiintindihan ba? Oh. Gets? Bakit Louis B? Again, kokonti lang yung nagagawang Louis A. Again, pag si Louis Jean lang ang ang involved, yun lang ang nagagawa. Okay? Yun lang ang nagagawa. Pero pag involved na si Jean, nagagawa na ang Louis B. Naintindihan? Or, sorry, kapag, again, small amount lang na number ng Louis A ang nagagawa. Guys, erase yung sinabi ko kanina. Again, basta wag kakalimutan. Si Louis A lang, ay kapag si Louis Jean lang ang involved, Louis A lang ang nagagawa. Wala nang iba. Yung other antigens na nagagawa, ang involved na is Louis B. Okay? O, balik tayo sa B. Ulit-ulit, Louis Jean codes for the enzyme, the fucosyl transferase, L, fucosyl transferase. Okay, assume natin, meron na dito si L-fucose, meron na dito si N-acetyl galactosamine. Ngayon, maa-add dito si, sino? L-fucose sa subterminal. Okay, sa subterminal natin na N-acetylglucosamine resulting to ano na? B?
Lewis B.
Louis B.
Louis B.
Okay. Okay na ba? Keri-keri boom boom. Anong 80, Wilfredo?
Sir, yung
Wilfredo,
sa
ano
Edging po kanina.
Ano sa Jean? Oo, isagot mo. Okay, yung percentage. Okay. Nagets ba to? Sige, magtatawag ako Ibig sabihin kung hindi mo nasagot yung ano ko, hindi ka nakinig Jovi. Ay, kunyari mahina signal. Jovi.
Sir,
Discuss mo ulit yung enzyme war.
sir, sa enzyme war, si Sejin at Louis Jean magko-compete.
Sige lang. Hayaan mo lang. Magsalita ka lang.
So sa una, sir, si Sejin po muna, sir. Si Sejin, i-code niya yung production ng L-fucosyl transferase. So therefore, maa-add yung immunodominant sugar na L-fucose sa terminal galactose.
Okay?
Ay, sir, mali. Si Louis pala muna, sir.
Sige lang. Go.
Sir, si Louis Jean, i-code niya yung L-fucosyl transferase.
Ay, makinig kayo Makinig kayo, guys.
Maa-add yung immunodominant sugar. Niya. So, magkakaroon na ng Louis A antigen.
Saan na-add?
Tapos, sir, next.
Saan na-add? Saan na-add yung L-fucose na immunodominant sugar?
Sir?
Saan na-add? Okay.
Sir, sa may subterminal N-acetylglucosamine.
Okay, oo. Chill
Tapos
ka lang, ha? Oo. Game.
Next naman na, sir, si Sejin, i-code niya yung production ng L-fucosyl transferase sa may ayun, sir. Tapos mag-a-add siya.
Saan nga?
say gene codes for the production of alpha-cocyl transferase. Tapos yun, mag-a-add na siya ng immunodominant sugar sa alpha-cose ng terminal galactose.
Baliktad ka. Baliktad ka. Mag-a-add siya ng immunodominant sugar na L-fucose sa terminal
Yes sir,
galactose.
yun.
Okay. Wag ka
Opo.
malito, ha? Okay, therefore, resulting to production of or formation of
Formation of Louis gene, sir.
Hoy!
Wait lang. Hindi ko
Hindi. Hoy, hindi na natawanan na.
Si gene pala, sir.
Ano Sejin? Wait lang. Kapag nangyari na yon, anong magbubuo? Anong antigen?
Sir, makakabuo na siya ng age.
Okay.
Age antigen on secretions.
Okay, very good. Huwag kang malito ha. Parang kinakabahan ka kasi.
Sige, sir.
Tuloy mo. Kunyari
tapos-
na-inherit tapos, parang nakikipag-away ka.
Hindi, sir.
Okay,
Sir,
tuloy
tapos
natin.
yung age antigens, imomodify niya pa si LE gene. Si Lewis gene.
Ano? Ano sabi mo?
Yung age antigen, sir, imomodify niya pa
Baliktad ka na naman. Si Lewis gene, imomodify niya pa yung age antigen or substance natin. Ganon. Nagigets mo?
Okay, sir.
Okay, very good. Okay, tuloy.
So, si Louis gene, i-code niya yung production ng L-fucosyl transferase. Mag-add ng immunodominant sugar ulit, sir. Producing Louis B age antigen.
Saan nag-add?
Sir?
Saan nag-add? Saan in-add yung immunodominant sugar?
Sa may subterminal, sir.
Okay, very good.
Sir, nakaka-produce na siya ng Louis B age antigen or yung age lab.
Okay, very good. Next tayo, dito na tayo sa kabila.
Tapos next naman, mag-code naman tayo ng aging na. Yung aging
ano magko-code na tayo ng aging? Tawa ako sa'yo, Joby. Sorry, Joby, naalala kita. I miss you. Parang ikaw yung parang kinakabahan lagi, no? Hindi naman.
Hindi, sir.
Okay, tuloy natin. Kasama ko lang yung kapatid mo last 3 weeks ago eh. Si Allen. Punta kaming Greenfield. Tapos
si Agin naman na, sir. For example, si Agin, magko-code na siya ng N-acetyl ano na yun, sir? Sir, i-code niya na si N-acetyl
galactosamine transferase.
yes, sir, yun.
Tapos,
mag-a-add siya ng immunodominant sugar. Magkakaproduce na siya ng
anong immunodominant sugar?
L-fucose.
Ha?
Yes, sir. Agin.
Ano
for the production of an N-acetyl chuchu.
And then chuchu.
Therefore,
add siya ng
add immunodominant sugar.
Anong immunodominant sugar?
Yung sir, yung N-acetyl galactosamine.
Okay, very good. Next.
Tapos after nun, sir, makakabuo mo siya ng insoluble antigen sa secretions.
Tuloy-tuloy natin. Paano pag naman na yung legend pa?
Tapos pag naman na yung legend,
i-modify niya ulit yung soluble A antigen. Tama? Tapos,
yes,
ano mangyayari?
Makakabuo lang din ng A Lewis B antigen. Tapos for example naman si B gene code for the production ng D-galactosyl transferase. Mag-a-add ng immunodominant sugar na D-galactose. Tapos yun, makakabuo na rin siya ng B antigen or soluble B antigen in secretion.
Okay.
Tapos next, so sir, di ba may Louis A? Louis A antigen na tayo.
Ano pinagsasabi mo?
Sir, sa may taas.
Tapos na yan. Wag mo nang pakialaman yan. Okay na, so tapos na, 'di ba? Meron na tayong A, Louis B antigen, B, Louis B antigen. Okay?
Yes, sir.
Okay, so 4 na antigens yung nabuo. Louis A antigens, Louis B H or H Louis B antigen, A Louis B antigen, and your B Louis B antigen. Oh, wag malilito. Ang dami-dami niyan, okay? Okay, let's proceed with this table. So, nasa Lewis blood group system tayo. So, na-lecture ko na yung on how your Lewis antigens are made. So, we have here the different genes. Your Lewis, C gene, your ABO genes, A, B, and H genes. Again, when these genes nag-interact, the substance or the secretions made are Lewis A, Lewis B, A gene, A antigen or A substance, B substance, and H substance. And their phenotype or their blood type now is ABH, Lewis A negative, B positive. Guys, as you can see, bakit negative ang Lewis A? Bakit negative ulit ang Lewis A antigen natin? Adrian Paul.
Sir, kasi nag-interact na po siya dun sa other genes para mabuo yung Lewis B antigen.
I'm asking you why, bakit doon sa, as you can see on the secretions, meron tayong Lewis A antigen. But the RBC phenotype of this patient, it's ABH, Lewis A negative, B positive. Bakit? Try to analyze. Bakit Lewis A negative na ngayon ang phenotype ng pasyente or ng tao? Bakit hindi na, when we talk about RBC phenotype, guys, we're talking about yung antigen sa surface ng RBC. Okay, when we test it serologically, nakaka-detect tayo ng antigen. Bakit dito, Lewis A negative, walang antigen, walang Lewis A antigen? Miss Ira Tumakay.
Yes, sir.
Yes.
Sir, yung pagkakaintindi ko po kasi noon, mas weak po kasi yung Lewis A compared sa Lewis B.
Again, what's your first word or statement? Mas
weak po yung Lewis A compared po sa Lewis B.
You're talking about the gene. Okay, pero, I mean, you have a point. Lewis A antigens kasi, napoproduce lang siya in small amount. That's why serologically, when we phenotype it, or their phenotype therefore is Lewis A negative. Bakit ang Lewis B is positive? Nadedetect siya sa RBC phenotype. Ang tanong, guys, nasa secretions lang siya. Anyone? Di ba nasa secretions lang siya? Bakit siya nandito sa surface ng RBC?
Ina-absorb siya ni, ano kasing pangalan nun?
Sino yun? And what's your name?
Sir, si Sales po, sir.
Sales, why? You're right. Na-absorb ang Lewis B antigen from the plasma, pumupunta or dumidikit siya sa surface ng RBC. Balikan natin yung sinabi ko last time dito sa Lewis blood group antigen natin. So, makikita niyo dito, Lewis blood group antigens are not synthesized by the RBCs. Ibig sabihin, hindi siya nagagawa sa RBCs. These antigens are made by tissue cells secreted into body fluids and plasma or secretions in general, and they are just absorbed onto the RBC membrane. So, dumidikit lang siya sa RBC membrane. Naintindihan ba? That's why phenotypically, when we test it serologically, guys, yung dugo ng pasyente, may nakikita pa rin tayong Lewis B antigen. So, ang RBC phenotype ng taong ito is ABH, Lewis A negative, B positive. Naintindihan ba? Next, antibodies. Guys, wala siyang nabubuong antibodies. Hindi tayo nakakabuo ng kahit negative siya. Ayan o. Di ba guys, Lewis A negative siya, di ba? Ang RBC phenotype, Lewis A negative siya, wala pa rin siyang antibody. Walang antibody ang tao na to. Okay? Next, Lele C, maliit na Lewis C ABH. Therefore, guys, kung mapapansin ninyo, silent yung Lewis gene. Tama? Maliliit. Silent yung Lewis gene. Therefore, ang mabubuo lang sa secretions natin is your A, B, and H substances. Therefore, the RBC phenotype is ABH, Lewis A negative, B negative, and the antibodies here are anti-Lewis A and anti-Lewis B. Okay? Ang antibodies nila, anti-Lewis A, anti-Lewis B. Next, Lewis, tapos session na maliit, ABH. Tama ba na Lewis A lang? Yes. Lewis A lang yung nasa secretions natin. Okay? Lewis A lang yung sa secretions natin. RBC phenotype is still... Guys, bakit? May tanong ako. Miss, sino pa to? Eunice. May tanong ako sa Eunice. Eunice, bakit dito, tingnan mo tong genes na nag-interact. Bakit hindi present dito yung ABH? Eunice.
Sir, kasi po yung sese po, sir, hindi po sila yung dominant, sir. Bali, wala po
Very good. Very good. Very good. Guys, sinasabi ko sa inyo, kung maiintindihan nyo lang etong diniscuss ko dito, maiintindihan nyo tong table na to. So guys, understand yung diniscuss ko last time doon sa flow ng enzyme war. Gets, guys? Kasi kailangan natin ng C gene, malaking C, para makabuo ng age substance muna before we make A and B substances. So as you can see, kahit meron yung A, B, and H genes natin dito or AB natin na genes dito, guys, silent naman tong C. So walang ma-produce na age substance. Kaya ang na-produce lang, Leia. Hello? Hello?
Sir. Yes, sir.
Yes, sir.
Okay. Bakit sa RBC phenotype may ABH? Ang RBC phenotype ABH, Lewis A positive, B negative. Bakit? Bakit may ABH dito? Tingnan nyo. Bakit may ABH dito? RBC tayo. Pinag-usapan natin yung RBC phenotype ng pasyente. Ay, ng individual.
Sir, kasi age gene yung kailangan para sa RBC.
Very good. Sino yun?
Pagatpatan, sir.
Miss Pagatpatan, you're right. Guys, if you still remember, di ba si age gene ang kailangan para makagawa tayo ng age substance, A antigen or A substance, or sorry, age antigen, A antigen, and B antigen sa RBC. And si C gene ang kailangan para makabuo tayo ng age substance, A substance, and B substance. So kung titingnan ninyo ng mabuti, itong interaction, sana tayo, sorry. At dito ba tayo? Oo. Interactions ng genes na to. Guys, meron pa rin tayong A, B, and H genes. Age genes. Guys, siya yung nagmo-modify ng precursor chain sa RBC. Pag meron tayong age gene, nakakabuo ng age antigen, tapos meron pa tayong A gene, B gene, therefore, RBC phenotype, ABH pa din. And check natin yung Lewis A positive, B negative, kasi meron tayong Lewis A substance or secretions. And as you can see, the antibodies lang ng taong nito sa plasma or serum niya is anti-Lewis B. Next, as you can see naman dito, lele, sese, maliliit, ABH. Sa substance or secretions, wala. Okay? Hindi present. Why? Kasi, ito, silent yung mga genes natin dito. Okay? So, tingnan natin, the RBC phenotype is ABH, Lewis A negative, B negative, therefore, the antibodies present, anti-Leia, and anti-Len. Next, as you can see, Lewis, malaki, sese, maliit, A, B, and silent yung age. Tingnan nyo na mabuti, ha. So, guys, present, malaki si Lewis, guys. So substance or secretions, anong makikita natin dito? Meron si Lewis A. Okay? Meron si Lewis A. Ano ngayon ang RBC phenotype ng taong to? It is now your Bombay. Isa siyang Bombay na may RBC phenotype na Lewis A positive, B negative, and the antibody produced anti-Len. Naintindihan ba? Yes. Next. Lewis, malaki, C, malaki, AB, AB, tapos maliit na age. Guys, Lewis, substance or secretions present, tama. Malaki si Lewis, so meron si Lewis A. Ngayon, meron si Lewis B, A, B, and age. Guys, we're talking about secretions. Bakit kaya meron si A, B, age dito? Maliit naman tong age natin. 'Di ba? Dapat wala yan. Tama ba? Who can explain? Salita lang. Yes.
Sir, kasi po
Anyone?
malaki po kasi yung CESR, yung SE. Ang Sejin po sir hindi naman po hindi niya po inaapektuhan yung production ng ABH antigen sir.
Saan?
Tama po ba sir?
Saan?
Sa
ABH
secretion
antigen.
sir. ABH antigen ng RBC sir. Hindi niya po
Very good. So we're
naapektuhan
talking,
sir.
tama. Sino to? Si Nolan ba to?
No, yes sir, Nolan Manaus po.
Okay. Thank you. Tama siya, 'di ba?
Thank you,
Tama. Guys, meron tayong AB and age substances or antigens sa secretions kasi meron naman si C. Uulitin ko, yung iba sa inyo siguro hindi naiintindihan tong table nito, but try to understand again at balikan yung sequence ng enzyme war natin, you'll further understand deeper itong table na to. So guys, itong taong to is a para-Bombay individual. AB, Lewis A negative, B positive, at walang antibodies. Okay? Guys, intindihin niyo yan. Nasabi ko sa inyo, pahirap ng pahirap yung topic natin sa blood bank. So let's talk about Lewis antigen. So yun nga, sabi ko kanina, Lewis antigens are widely expressed in secretions and plasma. Then, they are just absorbed onto RBCs. The Lewis antigens or substances found in the secretions are mainly glycoproteins. Tandaan, as are the ABH substances from secretors. Okay? So, the glycoproteins are composed of 80% carbohydrates and 15% of amino acids. In plasma, Lewis antigens are glycolipids or glycosphingolipids. These antigens are carried by lipoproteins present in the plasma that adhere to RBC membranes, forming now glycosylceramides. Okay? So here, sabi dito, the exact site of synthesis of Lewis glycolipids in the plasma is not known. However, it has been postulated that they may originate mainly from the intestinal tract epithelial cells, other exocrine organs such as your liver, kidney, and pancreas, and which also contribute to the plasma glycolipid. So, they are not well developed at birth. Ang Lewis antigens natin, not well developed at birth. And guys, cord blood and red cells from newborn infants are phenotyped as Lewis A negative, B negative. So, okay? So, guys, tandaan lang natin na may transformation yung phenotype ng newborn infant hanggang tumanda siya. So, magi-start yan. Okay, so magi-start yan, guys. Initially, daw, ang cord blood and the red cells from newborn infants, mag-start siya as Lewis A negative, B negative. Until later on, magiging ano siya? Magiging Lewis A positive, B negative. Tandaan to Lewis A positive, B negative. Next, magiging Lewis A positive, B positive. And then finally, Lewis A negative, B positive. So guys, ito yung transformation ng phenotype from newborn infants until hanggang tumanda sila. Okay, sabi dito, there is a decrease in expression of Lewis antigens. Nakikita daw siya sa red cells from any pregnant women. Bakit kaya? Okay? Mamaya. Sabi dito, lack of expression of Lewis antigens, Lewis A antigen, and B antigen has been demonstrated also on the RBCs of patients with cancer, alcoholic cirrhosis, and viral and parasitic infections. So Lewis antigens can freely interchange in 3 compartments. Okay, guys, yung mga Lewis antigens natin, di ba? Ano yung una yung nalaman? Guys, yung una yung nalaman, they are being secreted sa body fluids natin, sa plasma. So nakikita sila sa body fluids or mainly sa plasma natin. And they are just being absorbed sa RBC. So, ito lang gusto kong ipaintindi sa inyo. Kapag tumaas ang plasma volume natin, pag sobrang dami ng plasma volume natin, ang mga Lewis antigen will stay sa plasma. Therefore, decrease ang Lewis antigen na makikita sa red blood cell. Naintindihan natin? And gusto ko rin ipatindi sa inyo na kapag mataas din ang lipoprotein natin sa plasma or sa dugo natin in general, decrease ang Lewis antigens natin expression, Lewis antigen expression natin sa RBC. That's why guys, ang mga pregnant women kasi, increase kasi ang kanilang lipoprotein sa dugo. Kaya ang nangyayari, there is a decrease in expression of Lewis antigen sa red cells natin. So guys, again, conclusion, ito lang yung pinapoint out ko dito. Kapag mataas ang plasma volume natin, decrease ang expression ng Lewis antigen sa red blood cells natin. Kokonti ang napupunta doon sa surface ng RBC. Kaya pag finito-type natin yung taong yon, wala tayong ma-detect or very few. Again, pag mataas naman ang lipoproteins ng pasyente sa dugo, again, decrease naman ang expression ng Lewis antigen sa surface ng RBC. Okay ba? Naintindihan ba yon? Hello?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir. Okay. Let's proceed. So we have here the different antigens of Lewis, Lewis A, Lewis B, Lewis AB, Lewis B age, or A-leb, and your B-leb. Okay? So sige nga, question again. Tatawag ako ng isa sa inyo. Sino yung... we have Janine Bakiran.
Oh my God, sir.
Hi,
Yes
Janine.
po.
Tanong ko sa'yo, sinong gene genes responsible for the production of Lewis A? Sino-sino or sino? Or ano, sorry.
Si Legin po.
Ha?
Si Eligin po yung malaki, sir. Tapos, si Sejin po, sir.
Sure ka ba? Sure ka ba kasali si Sejin?
Yes. No, sir.
Ha? No.
Sir,
Final
no po.
answer. What's your final answer?
Yan lang, sir. Yan lang po.
Si Legend lang. Very good. Okay? Si Legend lang, ha? Miss Janine, ha? Okay. What about Joward Galapon? What about Lewis B gene? Lewis B antigen. Hello?
Hello, sir.
Hi. So what's your answer?
Sejin, sir.
Sorry, I can't hear you well.
Sir, Sejin po.
Sejin lang.
Sir. Yes, sir.
Si Sejin lang? Sure ka ba?
Yes, sir.
Sige. Kung si Sejin lang, ang mabubuo lang nito is age substance. Tama ba ako?
Yes po,
Yes,
sir.
sir.
Yes, sir.
Kulang ka. Kulang ka, Mr. Joward, right? Sino pa yung isang
Yes.
kailangan na gene? Hindi naiintindihan yung topic.
Sir, ba kasi ano?
Mahina yung internet mo. Thank you. Let's call Joshua Martinez. Joshua?
Hello po. Hello po.
Hi. Okay, can you please, help Mr. Joward?
Bali po, yung Sejin po kasi is needed po siya para ma-form yung H antigen natin. And then, for the formation one po ng ating Lewis B, kailangan po yung legend po.
Ha?
Yung legend po.
Kailangan yung legend.
Yes, sir.
Same siya dito sa lab age. Tama ba? Hello?
Sir. Yes po.
Tama ba siya? Tama ba? Yes, same lang yon. Okay, wag kayong malilito. Lewis B and lab age, same lang yan. Depende kung gaano kalakas yung gene. Okay? Next, Lewis AB. Ano naman tong Lewis AB natin? Kevin Talon. Kevin Talon. Hello? Wala siya. Corbin Lapuz. Hello? Hello?
Hello po, sir.
Hi, is this Corbin?
Yes po, sir.
Ano to? Anong sagot dito? Anong genes ang nag-interact sa pag meron kang Lewis AB? Iba to sa A Lewis B sa B Lewis B ah. Again guys, kapag nasa taas itong AB, ayan, Lewis AB, we're talking about Lewis antigen lang. Okay, malilito. Mag-iba siya sa A Lewis B. Magkaiba siya sa B Lewis B. Okay? Ano, Lewis AB. Corbin?
Sir, ganun pa, sir. Yung legend po ba, sir?
Sige. Lewis and Sejin ulit. Guys, nag-i-interact din tong Lewis and Sejin para makagawa ng Lewis AB. Okay, tandaan nyo tong mga to. Sige. I have a question. Hindi pa ako tapos sa'yo, Curb. Dito tayo sa lab age. May tanong ako sa'yo, Kirby. Pag-usapan natin yung antibody na anti-lab age. For example, may antibody na lab age, okay? Si anti-lab age, antibody to Lewis BH. Okay? Tama ba na si anti-lab age, magre-react siya sa O Lewis A negative, B positive? Itong antibody na to, magre-react siya dito sa antigen na to. O Lewis A negative, B positive.
Yes, sir.
Why? Explain.
Sir, kasi po yung O gene po.
Ano, hindi mo magets yung tanong ko. Natanong kita kung paano nagre-react si anti-Lev age kay O, Lewis A negative, B positive na red blood cell.
Hindi po, sir.
Hindi siya magre-react?
Magre-react po, sir.
Bakit? Ba't mo
Kasi
nasabing
po
magre-react? Merong?
May anti-H antigen. Ay, may anti-H po si LEBH po. Kasi may H
Therefore,
antigen po
kanino
si
siya
group O.
magre-react? Very
Dun po
good,
sa
very
group O,
good.
sir.
Okay, isa-isahin natin. Sabi mo may anti-age tayo. Ba't siya
Yes.
magre-react dito? Kasi si O, siya yung may highest concentration ng age antigen. Tama? Naalala mo?
Yes po, sir.
Next, isa pa, anti-Lewis B. Magre-react siya dito. Bakit? Kasi positive.
positive po, sir.
Merong Lewis B antigen.
Positive.
Guys, nagigets nyo ba? Nagigets?
Yes,
Hello?
sir.
Oo, ganun mag-analyze
Sir.
nito ha. Ganun mag-analyze nito. Okay. Next tayo. Tawagin natin si Maria Luisa Burigsay. Hello?
Yes, sir.
Okay, try to answer this. Magre-react ba si anti-Lewis B age natin kay Lewis A negative, B positive na RBC? Okay? Sige. Anti-Lev age, magre-react ba siya dito? Meron bang reaction na mangyayari?
Yes, sir.
Why?
Sir, yung sabi mo kanina na since Louis B, sir, nagre-react siya kay B positive. Tapos,
Okay.
yung sa 8, sir, wait lang.
Okay. Sige. Try to scan your note. At least alam mo kung saan yung babalikan mo. Try to scan your note.
Sir, wait lang po.
Ay, ano nangyari? Hello? Saan na siya?
Sir?
Ano nangyari?
Sir, actually, hindi ko po masyado nagigets yung sa 8 to, sir, since absent po ako. Ay, wala po ako last meeting.
Hindi. Isipin mo yung nasagot mo na kanina eh. Si anti-Lewis B, mag-reaction sa Lewis B antigen na present. Si anti-age, kaya siya mag-react. Ang A2 ba natin may age antigen?
Ay, yes, sir.
Yes. Nagets mo?
Ay, yes, sir. Gets na po.
Nagets? Nagets nyo? Hello?
Yes,
Yes,
sir.
Yes, sir.
Yes, sir.
Okay, okay. So, guys, figure out nyo yung mga genes dito, ah. Okay? Sige nga, last na. Anyway, basta ganun lang guys, ha, hanapin nyo. Madali lang naman siya eh. Letter lang naman. Basta alam nyo yung concept, maiintindihan nyo kung paano yung mga reaction. Okay, let's proceed. So, sabi dito, mga notes na kailangan tandaan. Okay? So, Lewis system is associated with factors causing diseases such as peptic ulcer, ischemic heart disease, cancer, and kidney transplant rejections. So Lewis antigens have receptors to interact with microorganisms expressing a particular lectin. And nasabi ko na to last time, Lewis B has a receptor for anong virus and bacteria? Yung Norwalk virus natin. And yung anong bacteria?
H. pylori.
Okay, Helicobacter pylori. Okay, and sabi dito, Helicobacter pylori induces
anti-Lewis antibodies that cross-react with gastric mucosa. Lack of Le and Segins in the Lewis A negative B negative phenotype is associated with increased risk for coronary heart disease. And sabi dito, Lewis X and Lewis Y are associated naman with diseases such as gastrointestinal, colorectal, and lung cancers. And sabi dito, Lewis X antigen is considered a marker for the Reed-Sternberg cells of Hodgkin's disease. Naalala niyo ba si Reed-Sternberg cells? Siya yung may owl eye appearance, right? 'Di ba? Reed-Sternberg cell is a lymphocyte na may which is abnormal na may owl, parang yun ata, owl's eye, tama ba? Reed-Sternberg, if you still remember. Hindi na maalala siguro. Anyway, so ano pang may papatanda pa pala ako sa inyo. Gusto ko rin tandaan sa inyo, pasulat pa-take note, hindi ko pala nailagay dito. Hindi nyo ba alam na ang under Lewis blood group system, may tinatawag tayong CA19-9. Associated siya dito sa tumor marker na to, si CA19-9. Guys, ano ang CA19? Anong ibig sabihin ng CA? Guys, anong ibig sabihin ng CA? Hello? CA19-9 is a tumor marker. Guys, kung makakakita kayo soon sa mga topics ninyo, may nakita kayong CA19-9, CA545, mga ganun-ganon. Ibig sabihin ito, carbohydrate antigen. Carbohydrate antigen 19-9 is a tumor marker and is considered and is thought to be, this is thought to be a sialylated Lewis blood group antigen. It is thought to be a sialylated Lewis antigen. Okay? Lewis antigen. This is a sialylated Lewis antigen. So guys, anong significance nito sa cancer? So gusto ko lang i-take note ninyo, pasulat dyan, na kapag meron kang CA19-9, okay, kapag meron kang CA19-9 sa plasma, okay, sobrang taas niya sa plasma mo, okay, this indicates na meron kang pancreatic cancer, or ito na lang, yung statement. Increase ang CA19-9 or sialylated Lewis antigen sa plasma ng individuals with pancreatic cancer or colorectal cancer and Mirizi's syndrome. Tatlo yun. Pancreatic cancer, colorectal cancer, and Mirizi's syndrome. Okay, try to research kung ano ang Mirizi's syndrome. Pero ito lang ipapatanda ko sa inyo. Mirizi's, double C, Z. That's Mirizi's syndrome. Okay? CA19-9. Soon, in your immunology, marami kayong aaralan na tumor markers. Sobrang dami. So, nakabigay na ako sa inyo ng isa, CA19-9. This is a tumor marker, also known as sialylated Lewis antigen and seen in the plasma of patients with high concentrations na may pancreatic cancer, colorectal cancer, and Mirizi's syndrome. So, as you can see here, yung mga phenotypes natin. So, ano yung mga phenotypes? Lewis A negative, B positive. Lewis A positive, B negative. Seen in 22% of white population and 23% of black. They are AB/AIDS non-secretors. Lewis A negative, B positive. Guys, this is the most common phenotype. Tandaan, Lewis A negative, B positive, 72% in whites, blacks, 55%. AB/AIDS secretors sila, and this is the most common phenotype. And guys, kung mapapansin niyo, Lewis A negative, B negative naman. So, Lewis A negative, B negative naman, 22% in black. So, nakikita siya sa mga African descent. Okay? White individual. And finally, kakaiba, both positive. Lewis A positive, B positive, which is very rare, seen in Asians. 10 to 40, pasulat, pasensya na. Nakikita siya 10 to 40% of individuals. Guys, dito naman na nila yung weak form ng secretogen, which is your SEO. Bakit nagkaroon ng SE or weak secretogen caused by point mutations in the coding region of your FUT2 or yung anong glycosyl transferase na ulit kasi si FUT2?
Glucosyl transferase.
Okay, L glycosyl transferase. Okay? Again, tandaan yung mga yan. Okay, bladder break muna tayo for 2 minutes.
2 minutes? 2 minutes.
Ako ba yun?
So, okay, I'm back. So, Lewis antibodies are naturally occurring, therefore they are IgM in nature. They can activate the complement and can cause in vivo and in vitro hemolysis. They do not cross placenta kasi nga IgM sila, therefore they do not cause HDN. So, Lewis antibodies are generally produced by Lewis A negative, B negative individuals or persons. So, Lewis antibodies are generally considered insignificant in blood transfusion. So this is because neutralization of Lewis antibodies by Lewis substance present in the plasma. As you still remember, guys, di ba, si Lewis is part nung table natin na sources ng substances natin for neutralization. Di ba sila ni Chido Roger? Naalala nyo ba? Okay. So, loss of red cell Lewis antigens into the plasma, lack of reactivity at 37 degrees Celsius and anti-human globulin phase, IgM in nature, and yun, Lewis antigens are also poorly developed in newborn. So, isa-isahin natin lahat ng antibodies ng Lewis. So, anti-Lewis A, most common siya. So, it is an IgM class, however, some may have IgG components or may be entirely IgG. So IgG form of anti-Lewis A does not bind to the RBCs as efficiently as the IgM form. Kasi alam niyo naman yung dahilan, di ba? However, IgG anti-Lewis A has been detected on RBCs using ELISA or enzyme-linked immunosorbent assay. IgM form naman binds your complement and cause in vivo and in vitro hemolysis. So sabi natin dito, the antibody reactivity is enhanced by enzyme-treated RBCs. Tama? Anti-Lewis A naman is easily neutralized with plasma or saliva that contains Lewis A substance. So sabi dito, naalala niyo yung topic natin dati na 'di ba, kapag antibodies are being neutralized kapag meron yung respective substance or antigen nila sa secretion, 'di ba? So persons who are Lewis A negative, B negative do not make anti-Lewis A. Why? Kasi nga, alam natin yan because only small amount or small amount of unconverted Lewis A are present in the plasma and saliva. Okay? Kaya hindi sila gumagawa. So anti-Lewis B naman classified into two categories, your anti-LEB-H and anti-LEB-L. Anti-LEB-H reacts best with Lewis B when both Lewis B and H antigens are present on the RBC such as group O and A2 cells. Yun yung binanggit ko kanina. Anti-LEB-L naman is the Lewis B antibody na nagre-recognize ng any Lewis B antigens regardless of the ABO type. Tandaan, anti-LEB-L. And this is the antibody of choice for phenotyping RBCs. Why? Kasi nga, it reacts with any ABO type. Anti-LEX naman or anti-Lewis X agglutinates Lewis A positive B negative, Lewis A negative B positive RBCs, and is formed by all individuals who are phenotype as Lewis A negative B negative. Okay, so we're done with Lewis blood group system. Let's proceed with MNS blood group system. Do you have any question sa Lewis blood group system natin? Hello? May question ba? Okay, mukhang wala namang question. Let's proceed with MNS blood group system. So your MNS blood group system, also referred as MN or MNS, big S, small s blood group system. So Landsteiner and Levin began immunizing rabbits with human RBCs, hoping to find new antigen specificities. Among the antibodies recovered from this rabbit sera were anti-M and anti-N, both which were reported in 1927. Genes produce two distinct glycophorenes or sialoglycoproteins on the RBC membrane. Again, chromosome 4 contains the linked genes. So, tatandaan, kakaiba to, your MNS antigens are located or the located and the genes are located doon sa glycophorenes or sialoglycoproteins ng RBC membrane natin. So sabi dito, M and N were taken from the word immunize. M and N were antithetical antigens. And S and small s, okay, taken from the word Sydney. S and small s were antithetical antigen. Okay? Pag sinabi natin antithetical antigen, these antigens are located or nakikita sa opposite chromosome. Okay? So, kung mapapansin niyo naman dito, so definitely guys, tandaan natin, there are mainly, ayan, M, N, big S, and small s. Yun yung mga kailangan tandaan. So, frequency of M and S phenotypes. So, M positive, okay, N negative. Ito na lang kailangan tandaan yung bibilugan ko. Kung mapapansin ninyo, sa white population, the most common na phenotype for MNS blood group system is yung M positive, N positive. Big N positive, N positive. Again, common siya sa white or Caucasian, about 50%. And sa black individual naman, the most common is big S negative and small s positive. So wag kakalimutan to. M positive, N positive, big S negative, small s positive. So, and guys, hindi lang pala yon ang mga antigens, hindi lang M, N, S ang mga antigens sa ating blood MNS blood group system. Meron ding U antigen which stands for universal. It is a high prevalent antigen. Pag sinabi natin high prevalent antigen, nakikita siya mostly sa population worldwide. Okay? It is a high prevalent antigen not seen in individuals who lack both S and S antigen. Individuals who lack this antigen, less than 1%, have a high likelihood of forming anti-big U as well as anti-big S and anti-small s. So anong ibig sabihin nito? Pag wala ka daw big S and small s antigen, ibig sabihin wala ka na ring big U antigen. Okay? And in white individual, Caucasian, the common haplotypes were calculated to appear in the following order of relative frequency. So we're talking about haplotype naman daw sa white individuals. Ano yung common haplotype sa white individual? These are, ito yung most common na NS, Susunod si MS. M to Susunod si Big S. And up next, Big N, Big S. So, yan guys. Huwag kakalimutan. Let's proceed. Pag-usapan naman natin ngayon yung antigens ng, okay, pag-usapan naman natin ngayon yung antigens ng MNS blood group system natin. So, let's start. There are 43 antigens sa MNS natin, making it almost equal to RH in size and complexity. Pero guys, pagtutuunan natin ng pansin, yung mga i-discuss lang natin ngayon. Start tayo. Big M and Big N antigens are found on. Tandaan, nakikita sila sa glycophorin A. A ha? Glycophorin A or what we call sialo-glycoprotein A. Huwag kakalimutan. M and N antigens differ in their amino acid residue position at number 1 and number 5. Dun sa 1 and 5 amino acid ni M, ang present dun na amino acid is si serine. Sa number 5 naman na amino acid natin kay Big M is your glycine. While kay Big N, guys, kay number 1, okay, iba, which is your leucine. Kay number 5 naman is your glutamic acid. Okay, huwag kakalimutan. MNN antigens are well developed at birth and they are easily destroyed or removed by enzyme because MNN are located at the outer end of glycophorin A in the membrane structure of your red blood cells. So antigens are also destroyed by ZZAP, a solution of dithiotretol and papain orficine. ZSAP is a combination of dithiotretol and papain orficine. Nasisira sila ng ZZAP, okay? But they are not affected by dithiotretol alone, AET, or your 2-amino-ethyl isothiocuronium bromide, chymotrypsin, chloroquine, or glycine EDTA treatment. So sabi pa dito, treating RBCs with neuraminidase, which cleaves sialic acid, also known as neuraminic acid or NUNAC, abolishes the reactivity with only some examples of antibody. So M and N antigens, hindi nakikita yan sa lymphocytes, monocytes, and platelets. And M and N have been detected on renal, capillary, endothelial, and epithelium sa kidney. So, tatandaan lahat ng characteristics ng M and N antigen. So, magpapalagpasin ni isa dyan. Okay? So, big S and small s antigens naman natin. Nakikita naman sila saan naman sila nakikita? Sa glycophorin B or your sialo-glycoprotein B. Or sa other books, tinatawag din tong CD235B. Right? So sabi dyan, kung ang M and N natin, they differ in amino acid residue position at number 1 and 5. Your S and small s antigens naman natin, okay, sa isa lang. Sa number 29 lang sila nagkakaiba. Ano kay Big S? Kay Big S, methionine. And kay small s, threonine. Big S, methionine. Small s, threonine. Again, well-developed din sila sa birth. And they are less easily destroyed or removed by enzymes, unlike M and N antigens. Hindi rin sila nakikita sa platelets, lymphocytes, monocytes, in addition to that, granulocytes, your neutrophils, eosinophils, and basophils. So, notes, sabi dyan, MNS antigens are important markers in paternity studies. So, sige, babalikan lang natin ulit. Glycophorin A, guys, anong antigens ang makikita dyan? M and N. Glycophorin B, S and small s. Sino si glycophorin C and D? O, ipapasok ko na kasi meron din si Gerbich. Kung mapapansin niyo, diba, narinig niyo na si Gerbich. Guys, glycophorin C and D, si Gerbich. Yung Gerbich natin na antigens. Pero soon, papag-usapan natin si Gerbich para okay na present ko na sa inyo yung apat natin na glycophorins, A, B, C, and D. A, doon located si big M and antigens, and glycophorin B, big S and small s antigens. And glycophorin C and D naman, Gerbich antigens. So again, tingnan nyo, big M and small s and U are considered high prevalent antigens, and big S is a low prevalent antigen. So we're done with antigens of MNS blood group system. Let's proceed with MNS antibodies. So anti-M is a naturally occurring antibody. So they are either IgM or IgG. Pero ito yung kailangan tandaan natin, yung naka-bold. Anti-M rarely causes hemolytic transfusion reaction, decreased cell survival, or HDN. However, when 37 degrees Celsius reactive IgG anti-M is found in a pregnant woman, the physician should be forewarned because some HDN cases have been severe related with anti-M. And some examples of anti-M, a recall question sa board exam. They are pH dependent. Yung mga anti-M daw natin, guys, pH dependent wherein they react best at what pH? 6.5. Guys, hindi lang. Tatandaan nyo yung dalawang antibodies, ha? May isa na kayong antibody na alam na nagre-react at 6.5 na pH. Si anti-M. Meron pa, anti-PR. Tandaan nyo, ha? Dalawang antibodies natin sa blood banking ang nagre-react best at a pH of 6.5. Anti-Big M and anti-PR. So, other examples of anti-M react only with RBCs exposed to glucose solutions. Next naman, anti-Big N. Ano naman si anti-Big N naman? So, they are called reactive GM or IgG, does not bind complement, and tandaan nyo na sa pinakababa, nakikita naman to sa patients with renal failure, regardless of the MN type, who are dialyzed on equipment sterilized with formaldehyde, si anti-Big N. Dialysis-associated anti-Big N reacts with N-positive or N-negative RBC treated with formaldehyde and is called anti-NF. Okay? Let's proceed. Anti-Big S and anti-small s, they are IgG and they are reactive at 37 degrees Celsius phase and anti-globulin test phase. They have been implicated in severe HTR with hemoglobinuria, extravascular hemolysis. They also caused HDN. So this is the summary ng antibodies natin. So anti-MN, mostly they are IgM, but some are IgG. And conclusion, they are clinically insignificant. Anti-S, small s, and U, they are IgG. And they are clinically significant at kailangang bantayan sa blood bank. We have here other lectins, your Bauhinia variegata, Bauhinia purpura, and Vicia graminea. May anti-N-like activity sila. And Iberis amara, guys, merong space yan. Vicia graminea, may space yan. Iberis amara, meron siyang anti-M activity. Kung meron tayong Bombay phenotype sa ABO blood group system, kung meron tayong RH-null syndrome sa RH blood group system, meron din tayong mga glycophorin A, glycophorin B deficient phenotypes sa MNS blood group system. May tinatawag tayong U phenotype or the universal phenotype. Okay? So the universal phenotype, U phenotype, wala silang pasulat, glycophorin B. Therefore, kung wala silang glycophorin B, anong antigens ang wala sila?
Big S and small S.
Big S, small S.
Meron pa. Si U, naalala ba? Di ba sinabi ko kanina, si universal antigen, kapag wala si S and small s, wala rin si U. Tama? Hello?
Yes, sir.
Yes,
Yes,
gumagawa
sir.
sila ng anti-U in response to transfusion or pregnancy. And tandaan, nasabi ko kanina, anti-big S, small s, and U are IgG and can cause HTR and HDN. Tandaan, therefore, meron, anong antigen lang meron sila? Therefore, your M and N. Na or Na negative, meaning envelope, wala naman silang glycophorin A. Therefore, wala silang
N, sir.
N antigen. Therefore, anong antigens meron sila? Big S, small s, and big U. Antigens meron sila. And kakaiba, tandaan na mabuti si MK phenotype. Guys, meron kasi tayong rare silent gene na MK and which was identified in 1964 by Metaxas and Metaxas-Buller. Si MK phenotype natin, wala silang both. Okay, wala silang both glycophorin A and glycophorin B. Therefore, wala ako. Glycophorin A and B. Therefore, wala sila nung mga antigens ng MNS blood group system. Wala silang M, N, big S, small s, and therefore wala rin si U. So, the RBCs of this individual type as M negative, N negative, S negative, S negative, U negative, but they had a normal, meron daw silang normal hematologic picture kahit wala tong mga antigens nito. Ibig sabihin, normal daw yung blood indices nila, yung red blood cell count, and etc. It is considered the true null phenotype in MNS blood group system. Just like your Bombay, di ba? A null phenotype, di ba? The MK-MK genotype is associated with decreased RBC sialic acid content but increased glycosylation of the RBC membrane bands 3 and 4.1. So disease association, tandaan ng mabuti, glycophorin AM serve as the receptor by which certain pyelonephritogenic strains of E. coli gain entry to the urinary tract. And the three, glycophorin A, B, and C23 are receptors for Plasmodium falciparum.
Start with our P blood group system. Okay, traditionally, the P blood group system is compromised P, P1, PK antigen, and yung latest na antigen natin is yung loop. Pero currently, pinaghiwa-hiwalay sila. Si P1, ginawa siyang yung P blood group system, which is yung ISBT number 3. P is yung globoside, which is ISBT number 28, at yung PK and loop. Tandaan din that yung P blood group system natin is related sa ABO, Lewis, at I blood group system. Kasi 'di ba, meron silang yung genes nila codes for enzyme. Yung enzyme na yon eventually add sugar sa ating precursor substance. Yung precursor substance ng P saka precursor substance ng O ay magkaparehas din sila. Makikita natin mamaya sa may illustration mamaya sa mga next pages. Tandaan din, all antigens are expressed on glycolipids sa red blood cell. Tandaan nyo din guys, yung di ba sa ABO, it's glycolipids, glycoproteins, ganun. Tandaan nyo guys yung biochemistry nung mga iba-ibang antigen natin sa red blood cell. You also remember kung saan siya nakikita sa red blood cell, WBC, ganun, mga tissues, ganun. I believe nasa handout yun ni Sir K. Lahat. Kasi hanggang doon guys, minemorize namin noon. Okay? So, if we look at the frequencies ng P antigens natin, P1 has greater expression sa blacks more than whites. Si P2 naman, more siya sa whites. Kung titignan natin yung antigens natin, P1 meron siyang P1, P at PK antigen. So, nasa kanya lahat ng antigen, therefore, we cannot expect an antibody against dun sa mga antigens na yun. Di ba nga yung ating Landsteiner rule, look, you cannot create an antibody against your own antigen. Okay? Pag si P2, wala siyang P1 na antigen, so therefore, bubuo ka ng anti-P1. Si P, small p is your P null. Yung P null natin, it's the null phenotype. Therefore, you don't have any antigen against it. So therefore, you have all the antibodies against all the antigens. And tandaan guys, P1 and P2 are the common phenotypes, while yung P1K at P2K are just rare phenotypes. Yung P null natin is common in Japan, North Sweden, and Amish, Ohio. Ito din guys, yung important factors na kailangan tandaan, yung mga lugar-lugar, ganun. Kasi parang may tanong daw sa board exam about sa Siena 2, sa Mennonite population. So, next naman is punta tayo sa ating biochemistry.
Hi, TJ, I just want to interrupt for a while. Kasi
Yes,
yung kanina, guys, yung sa quiz ninyo, na yung PP1, PK, and TJA are the same, di ba? Same name niyo yung
Yes, sir.
TJA and PP1, PK. So, guys, magpa-plus 2 na lang ako sa quiz niyo for other major blood group. Dapat na mali na tick ko dun sa lens. So, dapat correct answer dun is 2 choices are correct. Ayun. Thank you. Bye-bye. Sige. Mag-meeting lang ako, TJ. Thank you.
Yes, sir. Okay, let's sa biochemistry naman. RBC antigens of the P blood group exist as glycosphingolipids or glycolipids. Tulad ng sabi natin ito kanina, di ba? Biochemical analysis have shown that the precursor substance of P1 is also precursor substance of type 2 H change carried by EBH. Tulad ng sabi ko, tignan natin dito, yung common precursor nila is yung lactosyl ceramide or GB2, also known as the ceramide dihexose. Look at this, di ba? Same sila ng precursor substance ng EBH antigen. Lactotriosyl ceramide, tapos paragloboside, and yung paragloboside precursor sila both ng P1 antigen and ABH antigen. Di ba? Kaya nga sila related. And also, P and ABH antigen are same sila ng nature ng kanilang antibodies, which is IgM. Okay? So, let's proceed naman sa ating P antigens. Ulitin natin, P blood group antigens, like EBH antigens, are synthesized by sequential action of glycosyl transferase. Tandaan natin, the gene does not code for the specific antigen itself, but they code for glycosyl transferases. They code for specific enzymes. Yung enzymes na yon, siya yung responsible for the addition ng ating immunodominant sugar sa ating precursor substance. Okay, yung iba-ibang antigen natin, P at P1, P at PK, nakita sa RBC, lymphocyte, granulocyte, and monocyte. While yung P naman sa platelet, epithelial cells, and fibroblast. Okay? P and PK have also been found in plasma as glycosphingolipids and as glycoproteins in hydatid cyst fluid. Okay, P1 antigen. The P1 antigen, expression of P1 changes during fetal development. Nakita siya sa fetal RBC as early as 12 weeks of gestation, but it weakens with gestational age. Okay? And also remember, it is fully expressed at birth at 7 years siya bago siya ma-fully express. Okay? Sabi ko kanina, black has a stronger expression of P1 than in whites. At tandaan din natin yung suppressor gene na ating P1 antigen, which is yung ating INLU gene. Okay, ito yung pinakatandaan ninyo, P1 antigen deteriorates rapidly on storage. Kaya kapag magtitingin tayo, if we're looking after P1 antigen, we make sure na i-test natin agad yung blood na gagamitin natin. Okay? Okay. Let's proceed naman sa ating T antibodies. We have 6 na antibodies related sa ating T blood group system. Una yung anti-P1. Anti-P1 is a naturally occurring IgM antibody. Okay? IgM, anti-P1. That is a quickly cold reactive sa line agglutinin, optimally reactive at 4 degrees Celsius. Therefore, if it's reactive at 4 degrees Celsius, we can say that it's not clinically significant. Kasi ang antibody, masasabi natin clinically significant siya if it's reactive at 37 degrees Celsius. Okay? Pero, meron tayong rare examples ng anti-P1 na nagre-react sa 37 degrees Celsius. Therefore, can cause hemolytic transfusion reaction pero hindi HDN. Kuha ba? Rare examples ng anti-P1 pwedeng mag-cause ng HTR kasi nga some of them are reactive at 37 degrees Celsius pero hindi HDN kasi an antibody magkukos lang ng HDN pag ang nature niya is IgG kasi IgG lang ang kayang mag-pass ng placenta. Tandaan guys, rare example of anti-P1 can react at 37 degrees Celsius and cause HDN but not HTR. Kasi nga, yung nature ng antibody natin nature ng anti-P1 is IgM. So we have sources here, droppings of pigeons and turtle doves, egg whites or turtle doves, hydrolysis fluid, extract ng Lumbricus terrestris, liver flukes, such as yung ating Clonorchis sinensis and Opisthorchis viverinae. Sa micro namin guys, lumabas yung Clonorchis. Nagkakos daw ng cholangiocarcinoma. That's recall. Wala lang. Okay. Next naman is yung ating anti-PP1-PK, originally called as anti-TJA. Okay? Sulat natin. That's anti-TJA. T refers for tumor. Yung J kasi galing siya kay Mrs. J, a penile individual with adenocarcinoma of the stomach. Tandaan din that anti-PP1-PK, anti-PP1-PK reacts with all RBCs except those of penile phenotype. Tandaan yung anti-PP1-PK, pwede natin silang paghiwalayin through adsorption technique. Yung nature naman ng ating anti-PP1-PK, unlike ng ating anti-P1, it's IgG and IgM. Therefore, it can potentially cause hemolytic transfusion reaction and HDN. Okay? At ito naman, anti-PP1-PK is associated with spontaneous abortion in early pregnancy. Okay, guys, tandaan nyo yung spontaneous abortion kasi mamaya later meron tayong early habitual abortion naman sa next na antibody natin. Okay, next naman yung ating allo-anti-P or tinatawag din siyang anti-P. Allo-anti-P or anti-P, it's a naturally occurring allo-antibody in the serum of PK individuals. Okay, its reactivity is similar to that of anti-PP1-PK. However, it differs from anti-PP1-PK that it does not react with cells having an extremely rare PK phenotype and the individual making the antibody may type P1 positive. Ito, allo-anti-P is rarely seen but because it is hemolytic and with a wide thermal range of reactivity is very significant in transfusion. Okay? It's very significant in transfusion kasi wide range yung kanyang thermal reactivity. Okay? Yung ating IgG class ng ating anti-P, associated siya sa habitual early abortion. Diba si anti-PP1-PK kanina is associated with spontaneous abortion, while naman si ating allo anti-P, associated siya sa habitual early abortion. Okay? Auto-anti-P naman ay yung Donat-Landsteiner antibody. It's a biphasic hemolysin associated siya sa paroxysmal cold hemoglobinuria. Ano ba yung Donat-Landsteiner antibody? Yung reactivity niya. Si Donat-Landsteiner antibody, in cold temperature, magbabind siya sa RBC. Tapos pag in-incubate mo yung tube mo in 37 degrees Celsius, it activates complement and eventually lyse your RBC. Okay? Kaya siya biphasic hemolysis. Kasi yung antibody, it binds to red blood cell at 4 degrees Celsius. Pero pag nilagay mo siya at 37 degrees Celsius, ma-activate si complement, then malalays yung ating mga RBC. Ganun din yung ginagawa natin for sa ating Landsteiner test. Yung isang tube, i-incubate mo at 4 degrees Celsius. Yung isang tube naman, incubate mo at 37 degrees Celsius. Tapos yung test tube mo, you will incubate mo siya at 4 degrees Celsius and 37 degrees Celsius and look for lysis. Yun. Tanong to sa board exam namin yung reactivity ng Donat-Landsteiner antibodies. So, just remember that it is a biphasic hemolysin, tapos yung thermal reactivity niya. Okay? Next naman yung ating anti-PK. Anti-PK has been isolated from examples of anti-PP1 PK by selective adsorption and with P1 cells. Okay? Ito din, just remember nyo din yung mga disease association associated with different antibodies. Auto-anti-PK has been reported in the serum of P1 individuals with biliary cirrhosis and autoimmune hemolytic anemia. Okay? Meron din tayong antibodies to compound antigens. Example nun is anti-IP1. Ito, it is not impossible to have an antibody against a compound antigen kasi nga, sabi natin kanina, related yung P blood group system sa ABH, sa I, saka sa Lewis. Kasi nga, di ba, magkakapareha sila ng precursor, ng common precursor. Additional lang, guys, you just, siguro, i-copyhin nyo na lang isulat nyo na lang, okay? Isulat ko na lang din. Ito. I-side note lang naman. P1K react with anti-P1 and anti-PK but not with anti-P. Okay? P1K pasulat na lang ako sa notes video. P1K react with anti-P1 but not with anti-P. Okay, next naman tayong ating look. Look antigen sa ating look antibodies. Tipet et al. Describes an antibody in this room of patients with Hodgkin's lymphoma that divided the population into 3 phenotypes. Yung look positive, 84%, look weakly positive, that's 14%, and yung ating look negative, 2% lang. At tandaan, all P null and PK phenotype are look negative. Okay? Kasi yung P at saka yung PK phenotype natin lacks the P antigen. Okay? Ito naman sa disease association, pag anti-P1 associated sa parasitic infection. Anti-PP1-PK at anti-P early abortion. Yung pagkaiba nila, anti-PP1-PK, that's your spontaneous abortion, while naman yung anti-P or yung allo anti-P is yung ating habitual early abortion. Auto-anti-P sa ating biphasic hemolysin associated sa paroxysmal cold hemoglobinuria. Actually, laging tinatanong sa amin to noon, ano daw, anong nature ng antibody ang meron sa sa taong may PCH? Is it IgM, IgG, or IgM? Actually, laging napagbabaliktad to ng mga student kasi kinukuha sa name paroxysmal cold hemoglobinuria, cold, so therefore IgM sabi nila. Pero guys, tandaan, PCH, yung ating donut Lanzheimer antibody is an IgG, okay? IgG that binds to cold temperature, tas when you incubate it at 37 degrees Celsius, ma-activate si complement, then eventually leads to lysis, okay? Guys, kung may tanong kayo, just chat lang kayo or open your mic. Okay lang yun. P-system antigen associated sa urinary tract infection, yung ating uropathogenic E. coli. Okay? Uropathogenic E. coli. PK naman, associated receptor siya ng Streptococcus suis, which causes septicemia and meningitis in human. Receptor din siya ng Shiga toxin and EHEC, o yung ating enterohemorrhagic E. coli. Persons with PK antigen confers protection against HIV infection on peripheral blood mononuclear cell. At yung P antigen, tandaan, receptor siya ng parvovirus B19. Okay? Next, blood group system, I. Ating I blood group system is actually also IgM. Okay? Si Wiener et al. Give the name to call the glutamine called I, big I, and then big I for individuality. That was the non-reactive I. The non-reactive I negative specimen were thought to be from homozygotes of rare gene-producing small I antigen. The I negative phenotypes in adult is now called adult small I. Itong adult small I, sila yung mga tao na hindi nag-change ng structure ng kanilang I. Di ba? Meron tayong transition ng small I tapos magiging adult I. Sila yung mga taong big I negative, sila yung mga adult I kasi yung small I nila is hindi na-convert into big I. Okay? The I antigen together with small I used to compromise the I blood group system collection. Actually, this is 027, guys. It's 027. Kinarag din sa amin ito ni Sir Kinon, that's 027. Nasa notes ko naman. Okay? Tandaan, I and small I are not antithetical antigens. Rather, they are branched and linear carbohydrate structures respectively that are formed by the action of glycosyl transferases. So, para lang din siyang P saka ABH blood group system. Si big I antigen natin is a branch. Meron siyang branch carbohydrate structure. Si small I naman is meron siyang linear carbohydrate structure. Okay, I has been raised, so blood group system status meron sa the new I system. And has only one antigen yung ating I. At dadaan yung ating I is nearly found on all RBCs. Next naman yung ating I antigen. Both I and small I are high incidence antigen. Pag sinabi natin high incidence antigen or high prevalence antigen, meron to ng 97% ng population. Pag high incidence antigen, 97% of the population, meron tong antigen na to. Pag naman low prevalence antigen, less than 1% lang ng population ang meron ng antigen na yun. Okay na ko ba? But they are expressed in a reciprocal relationship that is developmentally regulated. Sabi ko kanina, di ba? Pag small I, pag dumalaki ka, it will eventually be converted to big I. At birth, increased small I And meron tayong undetectable na big I. First 18 months of life, little I is converted to big I. O, tanda. Ito din sinasabi ko kanina, not all little I are converted to big I. Some little I are still present of adult cells normally. So sila yung usually mga tao hindi na-convert yung kanilang small I to big I, tinatawag silang adult small I. Yung ating I negative phenotype. At common siya sa Asian. Di ba sa sa RH, meron isang phenotype doon na common sa Asian, which is yung DEL, di ba? Yung DEL na phenotype is also common in Asians. Itong adult small I, silang individuals who do not change their eye status after birth and do not express big I antigen on their RBCs. And remember that yung adult small I, mas madami silang small I antigen compared sa cord blood. Okay? Mas madaming small I antigen yung mga taong yung phenotype nila is adult small I than doon sa cord blood cell. And remember then, statement of RBC with enzymes enhances I and small I antigen. So, titignan natin dito yung reaction ng ating mga different phenotypes. Si adult big I have a strong reaction sa ating anti-I. Siyempre naman, diba? Si anti-small I, weak reaction. Ganun din si anti-IT. IT is for transition. T for transition, guys. Si cord blood, madami siyang small I. So, therefore, strong yung kanyang reaction sa anti-small I. At strong din sa transition natin. Si adult small I naman, we have a weakest reaction sa ating anti-IT. Okay, let's proceed naman sa ating antibodies. Anti-big I. Anti-big I is a common autoantibody that can be found virtually on all sera. Although testing at 4 degrees Celsius or again, enzyme treatment RBC may required to detect the reactivity. Yung classic reactivity ng ating anti-big I is, ang sulat natin, strong agglutination with adult I RBC. Find strong at weak reaction with cord blood. Yan. Weak, natural occurring,
So, tatlo yung main antibodies natin for the I blood group system, anti-big I, anti-small I, and anti-IT. T meaning for transition. Okay, pag-usapan natin isa-isa. Ano ba yung mga pinaka-importante characteristics na kailangan tinandaan? Anti-big I is, sir, nag-brown out po. Sabi niya, okay lang, ako na magtuloy. Tapos din meeting ko. Okay. It is a common autoantibody that can be found virtually all sera. Also, testing at 4 degrees Celsius and or against enzyme-treated RBCs may be required to detect the reactivity. So, what is the classic activity of your anti-big I? Paulit-ulit guys, sa table yan sa taas. Strong reaction with adult I RBC and a weak reaction in cord RBC. So wag kakalimutan yung mga reactions kasi guys, pwedeng ibigay ito as a tawag dito, case analysis. Okay? It is weak and a naturally occurring antibody sa line reactive IgM agglutinin with a titer level less than 64 at 4 degrees Celsius. So, cold reactive siya. Incubating test in the cold enhances anti-I reactivity and helps confirm its identity. And we have here albumin And enzyme methods also enhances the activity of anti-I. Again, this is IgM, so not associated with HDN and poorly expressed, and its antigens are poorly expressed on infant RBCs. So we have here two types of auto-anti-I, your benign and pathologic anti-I. So what's the difference between the two? So here, yung benign auto-anti-I natin, nakikita daw to in many of normal healthy individuals and can cause problem in pre-transfusion testing, meaning panggulo lang siya during pre-transfusion testing wherein we detect antibodies doon sa blood nung donor or nung patient before we transfuse the blood. And your pathologic auto-anti-I, very important, it is associated with your cold agglutinin syndrome. It is a strong IgM antibody and a broad thermal range of activity reacting up to 30 to 32 degrees Celsius. So typically, it reacts with adult and cold RBCs equally well at room temperature at 4 degrees Celsius. And attached in vivo and cause autoagglutinin and vascular occlusion, or what we call a Raynaud's phenomenon, or it can also cause intravascular hemolysis. So the production of auto-anti-I, mainly your pathologic auto-anti-I, may be stimulated by Mycoplasma pneumoniae. Again, what is Mycoplasma pneumoniae? Is it a virus or a bacteria? Hello? Ha? Mycoplasma pneumoniae, virus ba siya or bacteria?
Bacteria, sir.
Okay, very good. Mycoplasma pneumoniae is a bacteria. It is actually a, ano to? Di ba siya yung kakaiba na bacteria? Ano yung other term sa kanya? Tinatawag din siyang Eaton's agent, di ba? Yun yung lumabas sa quiz nyo. Tinatawag siyang Eaton's agent. Ayan, Eaton's agent. Okay? So, anong kinakos ng Eaton's agent or Mycoplasma pneumoniae natin? Nagkakos ng walking pneumonia, right? Ano pa yung isang bacteria? This is an organism from a patient with cold autoimmune hemolytic anemia, wherein it has been reported to absorb anti-I and stimulate its production in rabbits. Anong bacteria yon? Your Listeria monocytogenes. As we all know, Listeria monocytogenes are cryophilic. Okay, they live in a cold temperature. We have also anti-small I. Okay, anti-small I, most of the auto-anti-small I are IgM and they react best with saline suspended cells at 4 degrees Celsius. So yung classic activity niya dyan, very easy, strong reaction with cord blood cells and a weak reaction therefore with adult big I. So what are the potent examples of anti-I wherein it is associated with different disease or disease associations natin? So we have here, number 1, infectious mononucleosis. So your infectious mononucleosis is a disease, or your IM. Infectious mononucleosis is a disease wherein it is caused by what microorganism?
Epstein-Barr.
Epstein-Barr virus.
Okay. Guys, yung infectious mononucleosis natin, tinatawag din tong Kissing's disease. Kissing's disease, which is caused by what virus? Your EBV or your Epstein-Barr virus. Okay, ano ba yung kailangan nating tandaan? Guys, ang auto-anti-I or yung anti-I, anti-small I is only present in the plasma or serum of patients na may active state ng infectious mononucleosis na disease. Active state lang siya makikita. Okay? Only in the active state ng infectious mononucleosis natin madedetect or madedetect sa serum or plasma ng patient yung anti-small I. Guys, bakit na kasi si Epstein-Barr virus it is a receptor for what CD marker for lymphocyte? CD21, di ba? Nag-a-attach siya sa CD21 ng lymphocyte natin. Specifically, what lymphocyte? Ito yung medyo nakakalito eh. Guys, sa hematology, di ba nakakalito siya? Anong ini-infect niya na lymphocyte? B cell or T cell?
B. B, sir.
B cell or T cell? Hello?
B cell.
Very good. Epstein-Barr virus binds to the CD21 of B cells. Okay? Pero, sige nga, can someone please explain to me? Oo, ina-activate niyo yung, di ba, receptor siya for CD21. Pero meron pa eh, ina-affect niya rin ba yung T cell? Hello? Hello? Guys, sa hima ninyo, yung hematologic picture ng taong may infectious mononucleosis, sino nakakaalala? Anyway, well, nakalimutan ko siya. So, sige, babalikan ko kayo next meeting for that. Babalikan ko yung notes ko. Okay? So, ano pa yung kailangan nating balikan dito sa, okay, number 1, infectious mononucleosis. Number 2, diseases of reticuloendothelial system. Number 3, alcoholic cirrhosis. And number 4, leukemia. So, yung 4 na yan associated with anti-small I. So, IgG anti-I has also been described and has been associated with HDN. So, antibody na IT or anti-IT transition, mostly or IgM. So, ano naman yung kanyang classic activity? Strong reaction with cord RBC and a weak reaction with adult small I. So, guys, tandaan niyo to, naka-bold. Nakikita lang to sa population ng Melanesians and Yanomama Indians in Venezuela. Doon lang siya nakikita yung anti-I small t. So IgG anti-I small t reacting preferentially at 37 degrees Celsius. The first 4 cases were in patients with hemolytic anemia and Hodgkin's lymphoma. So disease association tayo, ulitin natin. Anti-big I, anong kailangan tandaan? Cold agglutinin syndrome or cold agglutinin disease and Mycoplasma pneumoniae, di ba? And anti-small I, anong kailangan pinakatandaan? Infectious mononucleosis or kissing disease caused by Epstein-Barr virus. And guys, may mga notes din ako dito, anti-IT, nakikita sa patients with Hodgkin's lymphoma. And ito din, increased small I antigen on RBCs naman. Meaning there is a shortened marrow maturation time or what we call dyserythropoiesis seen in acute leukemia, hypoplastic anemia, megaloblastic anemia, sideroblastic anemia, thalassemia, sickle cell disease or PNH, chronic hemolytic anemia, and appearance of reactive lymphocytes in patients with infectious mononucleosis. So ano pa? Chronic dyserythropoietic anemia type 2 or what we call your HEMPAS or your hereditary erythroblastic multinuclearity with a positive acidified serum test. And in Asians, the adult eye small phenotype has been associated with what we call congenital cataract. Okay, wag kakalimutan, congenital cataract, yung adult small eye. So marami na tayong kailangan tandaan sa mga Asians ha. Naalala niyo sa RH natin yung del mutation sa Lewis natin, anong tatandaan sa Asians? Meron silang, ano yung gene? Yung weak secretor gene na sew-sew. Naalala? Yes. What about sa MNS blood group system? May kailangan mo tayong tandaan sa Asian population?
Wala. Char.
Wala.
Wala, sir. Wala po.
Okay. Wala naman. O, ganun mag-alala ha. 'Di ba? Effective ang tawag dito, effective mag-aral kapag for example may nakita ka, for example Asians, may Asians ako nabasa, balikan mo, maaalala mo yon all throughout, promise. Yay. Okay, so KEL and KX blood group system. So your KEL and KX, it was the first blood group system discovered after the introduction of anti-globulin testing. Sabi ko sa inyo guys, very important pang mga nakabod, yung mga history about your blood group systems, very important. So anti-big K, originally called KEL, was identified in 1946 in the serum of Mrs. Kelleher. The antibody reacted with RBCs of her newborn infant, her older daughter, her husband, and about 7% of the random population. In 1949, Levine et al. Described anti-small k from the name Celano, the high-incidence antithetical partner to big K. These antigens are the third most potent after those of the ABO and RH at triggering immune reaction. So in terms of potency of antigen your blood group system, pinaka-potent pa rin ABO, susunod si RH, pangatlo si KEL. Huwag kakalimutan, ABO, RH, and KEL. So the KEL gene is found on chromosome 7. So as you can see here, a table, KEL system phenotype frequencies. So ano lang kailangan tandaan? Okay, i-highlight natin. Una, big K negative, small k positive, seen in white population, 91%, and in black, 96.5%. Next will be KPA negative, KPB positive, about 97.7% in white population and 100% in black population. And lastly, JSA negative, B positive, 100% in white population and 80% in black population. So as you can see, doon pa lang sa phenotype nila, makikita nyo na anong mga antigens ang pinaka-common. Kung mapapansin niyo sa unang part, small k, ito naman, KPB, and lastly, JSB. So these antigens of the KEL blood group system are considered the common antigens, okay? Common antigens in both black and white population. So tinagurian din siya, they are also considered high prevalence antigens of your KEL blood group system. Kasi sabi ko nga sa inyo, pag sinabi natin high prevalence antigen, this is seen in more than 97% of the population. Okay, tandaan nyo to. They are common antigens of your KEL blood group system. So, the KEL antigens of KEL blood group system are found only in RBCs, and K is rated second only to D in terms of immunogenicity or their capability of eliciting immune reaction or response. They are well-developed at birth, and kung mapapansin niyo, the antigens are not destroyed by enzymes but by combination of trypsin plus chymotrypsin, thiol-reducing agents such as 2-ME, EET, and your ZZAP. Okay? They destroy KEL antigens but not KX antigens. So glycine EDTA naman, an IgG removal agent which destroy also KEL antigens. Huwag kayong malilito guys ha. Magkaiba ang KEL sa KX. Okay? Ano lang yung similarity nila, makikita nyo mamaya. Kung mapapansin niyo, bakit may KEL at may KX? Okay, so balik tayo dito. So the major antigens of your KEL blood group system are big K and small k antigen, which are considered antithetical. So your big K, KEL1, is a low prevalence antigen, and history niyan, kinuha daw yan sa pangalan na Kelleher. Okay? Kelleher or Kelleher. Your Kel2 naman, small k, kinuha yan sa pangalan na Celano. Guys, ito yung mga first patient na wherein doon unang nakita yung mga antigens na to. KPA naman is Penny. KPB or Kel4 high prevalence antigen, kasi sabi natin kanina, is Rautenberg. Sorry, walang D. KPC walang pangalan yan, okay? Next, GSA, John Sutter. Nasa GSA tayo ha. GSA, John Sutter. JSB naman natin, si Matthews. Okay. Yung KU naman natin, Kel5, meaning KU universal. Okay. Same with dun sa uni MNS, di ba? And lastly, ano bang kailangan kay KM? Guys, i-note nyo kay KM ha, huwag kakalimutan. Si KM natin is present. Present lang daw siya if there is a K. Okay? Present if K glycoprotein and present if K glycoprotein, KX glycoprotein or XK glycoprotein. Again, ayan, KM present siya if K glycoprotein and KX or XK, pareho lang yan. KX or XK glycoprotein are present. Tatandaan ninyo, KM present siya kapag meron ang XK or K glycoprotein. So ano ba tong KX and XK glycoprotein na to? Okay? So baba tayo. Dito natin mag-iintindihan yung sinasabi kong Kel glycoprotein, KX glycoprotein, or XK glycoprotein. So the N-terminal domain is intracellular and the large external C-terminal domain is highly folded by disulfide linkage and is considered extracellular. So mapapansin niyo sa picture, the Kel glycoprotein is covalently linked with another protein called KX protein or XK protein by a single disulfide bond. So kung mapapansin niyo dito sa picture natin guys, this is your Kel glycoprotein which carries all the Kel antigens and this one is highly folded. And this is extracellular, nasa labas ng cell. Okay? For example, this is your RBC. The surface or the membrane of RBC. Okay? So this is your XK protein naman. They are intracellular. Your XK protein or your KX glycoprotein, they carry naman your KX antigen. Wag malilito. And tandaan, your KX or your XK glycoprotein and your Kel glycoprotein are connected with each other with a single disulfide bond. Okay? Okay, tandaan yung structure ha. Baba tayo. Sabi dito, Kel glycoprotein consists of 731 amino acid and spans the membrane once. Tama. It spans your RBC membrane once. Tama. As you can see on the picture, it is a member of the M13 neprilysin family of zinc entopeptidases and has been shown to cleave big endothelins. And your KX protein naman consists of 440 amino acids and is predicted to span the RBC membrane 10 times. Okay? 1, 2, 3, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay? That's your KX protein or XK protein. Wag malilito. Note, Kel antigen expression is dependent upon the presence of XK protein, meaning the absence of KX protein results in MacLeod syndrome. So anong ibig sabihin yan? So ibig sabihin yan, pag wala kang, pa-note to Ibig sabihin yan, kapag wala kang XK protein, ibig sabihin, anong wala sa'yo? Wala kang KX antigen. Tama? Tama. Okay, wala kang KX antigen. Ano pa? Meron pa ba?
KM, sir.
Very good. Wala ka ring KM. Okay? Wala ka ring KM antigen. Very good. KM antigen. But, eto na lang. Pag-usapan natin na mabuti itong MacLeod syndrome. Ang MacLeod syndrome kasi, this is considered the true null phenotype, okay, of your K blood group system. Sorry, hindi pala siya true null phenotype. Sorry. Erase. Sige, wait lang. Okay. Ito na lang, tandaan yung tatlo. MacLeod syndrome. Si MacLeod syndrome, para hindi kayo malito soon, kasi ito lang naman tinatanong madalas sa KEL blood group system eh. Pasulat, wala silang XK protein. Therefore, kapag walang XK protein, sinabi ko kanina, wala silang KX antigen and KM antigen. Wala silang KX antigen and KM antigen. Ano pa? Again, pag wala rin silang KEL protein. Okay, wala silang KEL glycoprotein. Mali. KEL null pala. KEL null. Sorry guys, sorry. Paulit na lang. Ulitin ko. Dalawa. Ito na lang pala para maintindihan ninyo. Dalawa kasi yan, may KEL null at MacLeod syndrome. Ang KEL null, ito lang tandaan nyo, lack XK protein, wala silang KX and KM antigen. Okay, dalawa lang. Ito. Yung KEL null naman natin, by its name, wala silang KEL antigen. Therefore, no KEL antigens present. Wala rin KM, but increase yung expression ng KX antigen. Naintindihan ba? Naintindihan ba yon? Ulitin ko, yung MacLeod syndrome natin, wala silang XK protein, wala ring KX and KM antigen. Okay? And si KEL null naman natin, walang KEL protein, therefore wala silang KEL antigens. Okay? Wala ring KM antigen and increase ang expression ng KX antigen. Okay? Sige, isulat nyo muna yon para mamaya you'll find out why. Para mas madaling maintindihan yung mga susunod na topic. So, genetics. The KEL gene located in chromosome 7, no KEL haplotype has been shown to code for more than one low-incidence antigen. People who test positive for 2 low-incidence KEL antigens have always been found to carry the encoding alleles on opposite chromosomes. Meaning, for example, someone who types KPA positive and JSA positive is genetically KKPA JSB on one chromosome and KKPB JSA on the other. So, naintindihan ba yon? So, sabi ba dito, a rare silent allele at the KEL locus has been designated KO. The XK gene, which encodes the KX antigen, is independent of KEL and is located on the X chromosome at position XP21. So guys, ito na yung sinasabi kong KEL null. A rare silent allele at the KEL locus has been designated KEL null. So ibig sabihin, pag KEL null ka or KO, hindi ka gumagawa ng, wala kang XK protein. Wala kang KEL protein, balikan. Wala kang KEL protein, therefore, wala kang KEL antigens at wala kang KM antigens. Therefore, mataas ang expression mo ng XK protein. Kasi sabi dito, the XK gene which encodes the KX antigen is independent. Wala siyang pakialam sa KEL gene, which codes for KEL glycoprotein. Okay, naintindihan ba yon? Okay. So pag-usapan naman natin yung K and small k antigens natin. So big K antigens and small k, excluding ABO, K is rated second only to D na sabi ko na yan. Sabi pa dito, when K-negative people are transfused with unit of K-positive blood, the probability of their developing anti-K may be as high as 10%. Why? Sige nga, can someone please explain this? Bakit kaya? Bakit daw ang mga K-negative people, when transfused with a unit of K-positive blood, the probability of their developing anti-big K may be as high as 10%? Paano nyo siya iintindihin? Guys? Anyone? Guys, balikan niyo yung frequency kasi as you can see, yung K-positive individuals natin dun sa may, yung K-positive, about 10% or 8.8% kasi ng white population natin are K-positive. Parang ganun lang siya. Huwag malilito sa mga ganun na. Kasi guys, maraming numbers dito na parang, paano nangyari yun? Paano nangyari yun? Approximately lang naman, probability lang naman tong mga to. Pero tinatandaan namin, pinatanda kasi sa amin eh. Kasi nakalagay siya sa book mismo, okay? So fortunately, the incidence of K antigen is low and the chance of receiving a K-negative unit, a K-negative unit is small. Negative yan. Okay, so majority of the people are negative to big K antigen and anti-small k is seldom encountered. Majority of the population kasi is K positive. So KPA and KPC are LPA and KPB is HPA. KPA is found in 2% of whites and KPA gene is associated with suppression of other KEL antigens on the same molecule. So may bago na naman kayo tatandaan. Guys, kapag na-inherit natin ang KPA gene, it is associated with suppression. Kaya niyang isuppress ang KEL antigens on the same molecule, including small k and JSB. Huwag kakalimutan. JSA and JSB antigens naman found in 20% of blocks but in fewer than 0.1% of whites. So anti-big K, so anti-big K, outside the, yun nga, paulit-ulit tayo dito. So ano lang kailangan tandaan? Okay, anti-big K is usually IgG, reactive in the antiglobulin phase. Naturally occurring IgM examples of anti-K are rare and have been only associated with bacterial infections such as E. coli O125B15 infection and others such as Mycobacteria, E. faecalis, Morganella morganii, Campylobacter jejuni, and Campylobacter coli. So, they are also implicated in severe HTR and severe HDN. So, sa severe HDN natin, there is a fetal anemia and associated with suppression of erythropoiesis due to destruction of erythroid precursor cells. Yung mga immature cells, yung nasisira, rather than destruction of circulating antigen-positive RBCs. So tatandaan ninyo kasi ngayon ko nasasabihin sa inyo, there are 3 types of HDN. May ABO HDN, may RH HDN, and may KEL HDN. So ito yung main characteristic ng KEL HDN. Severe din siya. There is an anemia doon sa fetus, and very distinct characteristic, there is a suppression of erythropoiesis kasi guys, nasisira mainly yung mga blast cells natin or yung mga immature or erythroid precursor cells natin. Unlike sa ABO and RH, soon malalaman ninyo nasisira yung mga mature cells kaya nagkakaroon ng jaundice yung bata. Okay? Soon malalaman ninyo yung yellowish skin color ng baby. Okay? Yun muna yung kailangan tandaan. So antibodies to KPA, GSA, and other low incidence antigens, antibodies to low incidence KEL antigens are very rare because few people are exposed to these antigens. Okay, very easy. Antibodies naman to small k, KPB, JSB, and other high incidence KEL antigens, ayan din. Antibodies to high, rare because so few people lack these antigens. So pag-usapan natin, other notes na kailangan tandaan. The KX antigen is present on both RBC and white blood cell. Guys, pero yung KEL antigen nakikita lang sa RBC, okay? KEL genes converted KX substances into the KEL antigens on RBCs but not on white blood cells. Nagets yun? The KEL genes convert KX substances into the KEL antigens on RBCs but not on white blood cells. KX is present on all RBCs except those of rare macleoid phenotype. Again, sinabi ko kanina na sa macleoid phenotype, walang XK protein. Therefore, or KX protein. Therefore, walang KX antigen present. When KEL antigens are denatured with AET or DDT, expression of KX increases. Sabi ulit dito when KEL antigens nasira daw ng AET or DDT, guys, mas magi-increase yung expression ng KX antigen natin. Okay? Pero vice versa, walang pakialam si KX kay KEL. Pero si KEL kumakapit kay KX. Nagigets nyo ba? Parang love life lang yan. Diba? Parang si KEL, dependent siya kay KX. Pero si KX, hindi siya dependent kay KEL. So wala siyang pakialam kay KEL. Ganon lang siya intindihin. Okay? So KX is carried on a separate protein. Ayan nga, yung KX or XK glycoprotein natin, which is encoded by a gene on the X chromosome, KX, and has been placed now on its own blood group system called XK or KX. So the KEL-null, na-discuss ko rin si KEL-null kanina, and anti-Q. Ano tong anti-Q? KEL-null is a silent KEL allele. So sabi dito, inheriting the two KEL-null genes resulting in a recessive null phenotype. So yung mga KEL-null cells natin, kapag may KEL, when you are KEL-null phenotype, ano yung itsura ng KEL-null cells natin or KEL-null RBCs natin? Wala silang, tingnan nito there is no membrane abnormality and the survival of red cells is normal in the circulation ng tao. Pero wala silang expression ng lahat ng KEL antigens. Lahat ng KEL antigens, big K, small k, JSA, JSB, KPA, KPB, wala yan. Hindi sila na-express or hindi sila present sa surface ng RBC. And this is very rare, seen in a ratio of 1:25,000 in white population. At kakaiba sila, gumagawa sila ng kakaibang antibody, tawag natin dyan, anti-Q or K5, which recognizes now your universal KEL antigen, KU, present on all cells except KEL-null. Naalala nyo ba yung sinabi ko sa... tama. Okay? Ulitin ko si anti-KU is present sa lahat ng cells except sa KEL-null. So anti-Q is very significant. Why? Because it causes HDN and HDR. So special topic, the macleoid phenotype and syndrome. Guys, mostly, ang nilalabas lang kasi sa KEL and KX blood group system about macleod. So, naglagay ako ng special topic dito na magpo-focus tayo, which is, guys, ang macleod, i-discuss to sa IS at Hemani nga na-discuss na siya. So, meron na kayong background. Pero, pagtutuunan natin ng pansin ngayon, yung hematologic picture niya and yung sa blood bank. Okay? So, sabi dito, the macleoid phenotype and syndrome. Allen et al. Described a young male blood donor who initially appeared to be KEL-null but who demonstrates weak expression of small k, KPB, and JSB detectable by adsorption elution methods. This unusual phenotype was called macleod after the donor. So ano bang pinagkaiba ng ano ba ang macleod phenotype natin? So sabi dito, okay, akit tayo ulit. This is very rare. Okay? X-linked pattern of inheritance. Kung mapapansin nito, tandaan nyo naka-bold. Your red blood cells, wala silang KX and KM antigen. And mark depression of other KEL antigens. Okay? Or ibig sabihin, decrease yung expression ng KEL antigens. Again, magkaiba ang lack sa decrease ang expression. Sa macleoid phenotype, wala talagang KX and KM, pero guys, decrease lang or decrease ang expression ng KEL antigens dito. So the weakened expression of KEL antigens is designated by a superscript W, weak, K negative, K positive, W, KPA, A negative, B positive, W. So ibig sabihin, kapag ganito yung phenotype ng isang taong may macleoid phenotype, weak yung expression ng small k antigen niya and weak yung expression ng small ng KPB antigen niya. Okay, individuals with macleoid phenotype have a variety of muscle and nerve disorders that together with the serologic and hematologic picture are collectively known as macleod syndrome. So, tinatawag na siyang syndrome kapag meron ng muscle and nerve disorders with its hematologic picture macleod syndrome na ang tawag doon. So, tingnan natin ang itsura ng red blood cell or mainly the hematologic picture of patients with macleoid phenotype. So, ano bang itsura? Acanthocytic. Na alam niyo to, di ba? Merong irregular shapes and protrusions. The RBCs also meron ding decreased deformability, acanthocyte, okay, and reduced in vivo survival. So, sabi pa dito, develop a slow progressive form of muscular dystrophy between ages 40 and 50 years and cardiomegaly, paglaki ng heart, leading to cardiomyopathy. Neurologic disorders presents initially areflexia, a lack of deep tendon reflexes, and progresses to coriform movements, well-coordinated but involuntary movements. So these individuals also have elevated creatinine phosphokinase levels of MM type kasi nga ang affected is yung muscles natin, mainly cardiac and skeletal muscles, and carbonic anhydrase 3 levels. So, rarely associated with X-linked CGD or chronic granulomatous disease, wherein there is a CYBB gene deletions. So guys, ang macleoid phenotype natin, associated daw siya sa CGD when there is a CYBB gene deletions. Deletion. There is a characteristic inability of phagocytes to make NADH oxidase, an enzyme important in generating hydrogen peroxide, which is used to kill ingested bacteria. So other diseases, association, Duchenne muscular retinitis pigmentosa. Macleoid with CGD makes anti-KX and anti-KM. Tandaan, therefore, yung cells nila, itong antibodies nito nagre-react strongly with kelnal RBCs, weaker with KEL phenotype RBCs, and not all with macleod phenotype RBCs. And macleod phenotype CGD with the macleod without CGD, males o makes anti-KM only. So tatandaan niyo yung mga yan. So, yung mga altered expression din ng KEL antigens, na-discuss natin yan, macleod phenotype, ano pa ba? Suppression by the KPA gene. Nasabi ko kanina, pag namana si KPA gene, masusuppress yung expression ng KEL antigens. And tandaan, yung mga taong may RBCs na may Gerbich negative phenotype, again, kapag ikaw may Gerbich negative phenotype ka, such as Gerbich negative 2, negative 3, and Gerbich negative 2, negative 3, and negative 4, ma-alter din yung expression mo ng KEL antigen. K-mod naman, very weak KEL expression, often requiring adsorption elution test, and some individuals make antibody that resembles anti-Q. Guys, kanino kasi si anti-Q? Kay KEL null. Pero tatandaan ninyo, yung anti-Q ni K-mod does not react with other K-mod RBCs, unlike anti-Q made by KEL null individuals. So, kung meron ka din autoimmune hemolytic anemia, meron kang altered expression of KEL antigens, and when you are infected with Streptococcus pyogenes. O sige nga, i-discuss natin to para mas madalian tayong intindihin. Wait lang. Mas madalian tayong intindihin yung mga reactions ng ating different, yan, yung Kelnol, Kmod, and Macleod. Pasulat, Macleod with CGD. With CGD, yung di-discuss ko dito kasi hindi naman importante yung without CGD. Start tayo. Sa normal individual, therefore, kapag normal ka, of course, normal, sulat, normal ang expression ng KEL antigens mo, pero weak ang expression ng KX antigen mo. Ganun siya guys ha. Normally, normal yung KEL antigens kasi guys, protruding siya, nasa labas siya ng membrane. Yung KX naman natin, mapapansin niyo intracellular siya. So, konti lang yung na-express na KX antigen natin. Okay? Next, KM natin, therefore, normal din. Okay? Normal din. Anong antibodies meron ka? Depende. Okay? Depende kung anong KEL antigen meron ka. Tama? Naintindihan ba? And RBCs natin dito, itsura niya, normal din. Ano yung normal shape ng RBC natin?
Discoid, sir.
Okay, discoid. Okay. Kelnal. O, sige nga pa-answer. Kelnal, magtatawag ako. Si Julie May. Julie May. Hello? Hello? Ay, wala siya. Ano pa ba? Mikey Mandela. Mikey? Mikey. Hoy, ano kayo? Sige, si Nika Morgado. Nika. Nika Morgado.
Sir.
Yes, sino
Hello
to?
po. Nika po.
Sige, sa pasagot naman to. Paano pag Kelnal ka? Meron ka bang KEL antigens?
Wala po, sir.
Okay, so absent yung antigen mo. What about KX?
KX. Wait lang po.
Diba sinabi ko kanina sa inyo guys, yung KEL protein ba natin dependent siya kay KX protein?
Yes po.
Hoy. Dependent siya? Oo, tama, di ba? Pero si KX, dependent ba siya? Si KX, maapektuhan ba siya pag wala si KEL?
Hindi, sir, kasi independent siya, sir.
Therefore, present si KEL, di ba? Ay, si KX, sorry. Present si KX, di ba? At increase yung expressions niya, guys. Increase yung expression niya. Nagigets ba? Hello, guys? Nagigets ba ako?
Yes, sir.
Yes po.
Yes po.
Okay, what about KM? O si KM, ano yung sinabi ko kanina? Si KX, hello? Absent ba siya? Actually, absent or weak. Okay? Wala siya minsan or minsan weak siya, si KM. Ano yung pinatanda ko kanina sa inyo kay KM? Balikan nga natin para mas masagot nyo na maayos. KM, di ba present lang si KM kapag merong K-glycoprotein or KX-glycoprotein. Naintindihan? Hello?
Yes po, sir.
Tingnan ninyo guys, absent ang KEL antigen, so walang KEL glycoprotein, pero present naman ang KX. So ibig sabihin si KM, minsan absent, minsan weak. Nagigets? Isipin. Okay, next. Anong antibody ang pwede mong mabuo? O, ano yung sinabi ko kanina? Anong antibody yun? Nika? Nika? Anong kakaiba na antibody meron si Kelnal?
Antay-Q.
Okay, anti-Q. And anong itsura ng RBC? Kapag Kelnal ka, guys, normal pa din. Okay, normal. What about K-mod? K-mod, Namir. Hello? Hey, anybody home? Guys, asa na kayo? Wala kayo. Sige, mag-recite na lang yung gusto mag-recite nga. Nahihirapan ako sa inyo. Hello?
Sir, very big, sir.
Sino ba yan? Sino?
Sir.
Anong pangalan mo?
Sir.
Anong proglin? Ano?
Very weak, sir.
Jerry Vic.
Very weak, sir.
Very weak daw, sir.
Natanong ko kung anong pangalan mo. Shoota ka. Ay, sorry. Very weak. K-mode. Yes, very weak. Very good. Very weak. Bakit? O, sige nga, sino nagsalita? Tinatin galing mo. Char. K-mode, very weak. Ano yung sinabi ko sa K-mode kanina? Kakasabi lang, very weak. Ayun o, di ba? Very weak. Very good. Ang galing mo naman magbasa. Char. Anyway, KX. Present ba si KX?
Sir, present.
Absent.
Sir, present might be elevated, sir.
Ano? Bakit absent? Sino nagsabi, Nolan, bakit absent?
Sir, present po.
O, teka lang. Sino yung nagsasalita? Hoy, sino ka?
Sir, joke lang. Nagkamali ako, MacLeod yung tinitignan ko, sir.
Hi. So, present. Very good. Present. Next, KM. Very weak, present. So, ano din? Present din to, pero weak. Okay, very weak. Okay? Next, antibodies ni K-mode.
Sir, anti-Q-like, sir.
Hi. Anti-Q-like. Okay, anti-Q-like. Diba? It resembles the anti-Q of Kelnal. Sige nga, ano yung pagkakaiba? O, sige, para wag malito. Yung anti-Q ni Kelnal. Si anti-Q ni Kelnal, guys, saan lang siya nagre-react? Si anti-Q ni Kelnal, ito lang anti-Q ni Kelnal, kaya niyang mag-react with RBCs of K-mod. Pero yung anti-Q-like, para wag tayo malito, pero yung anti-Q-like ni K-mod, hindi siya nagre-react. Okay, do not react with Kelnal and K-mod. Nagets ba? Hello?
Yes
Hello?
po, sir.
Okay, next. Ano yung itsura ng RBCs kapag may K-mode ka, normal pa rin. Okay, normal pa din. Okay, MacLeod with CGD. O, alam nyo na to. MacLeod with CGD. Pag meron kang MacLeod syndrome, yung kailan antigens mo, weak lang, di ba? Hello? Pero
Yes,
wala,
yes,
pero
po, sir.
wala kang TX protein. At kakaiba, guys, absent na dito ang KM antigens natin. And anong antibodies meron na nabubuo ka? Guys, with CGD, kakasabi ko kanina, anti-KM and Anti?
KX.
KX. And guys, anong itsura nung nung RBC?
Acanthocyte.
Acanthocyte.
Okay, meron siyang acanthocyte, right? Okay? So, ayun na nga. Anyway, so let's start with Duffy blood group system. So sa Duffy blood group system natin, okay, 008, designated by the symbol FY. Okay, yung Duffy blood group system natin is designated by the symbol FY. So bakit FY? Sabi dito, it was named for Mr. Duffy, a multiply transfused hemophiliac who in 1950 was found to have the first described example of anti-Duffy A. Off na nga lang ako ng camera. Yan. 1 year later, the antibody defining its antithetical antigen, Duffy B, was described by Ikin et al. In the serum of a woman who had 3 pregnancies. So, guys, the gene location for our Duffy blood group system, chromosome 1q, and remember that chromosome 1q was the first human gene assigned to a specific chromosome. And take a look and check, of course, yung frequency of Duffy phenotype. So, tandaan lang natin, sa Chinese population, Yan. Sa Chinese population, about 90.8% ang Duffy A positive, B negative, meaning ang predominant antigen meron sila is Duffy A. So yun yung kailangang tandaan. In white population naman, okay, una, Chinese population, and next tayo, white population, the predominant phenotype is Duffy A positive, B negative, meaning ito pala, parehong 49% sa white ng Duffy A positive, B positive, and 34% sa white naman ang Duffy A negative, B positive. Okay? So sa white population, ito yung most common phenotype. And kung mapapansin natin sa American blacks or sa mga black individuals, guys, they are negative with both Duffy A and B antigens, meaning their phenotypes, ayan, Duffy A negative, B negative. So ano ba yung mga kailangang tandaan dito? So may notes tayo na kailangang tandaan. So pag tinanong kayo sa mga exams ninyo or ano man yan, what is the most common genotype in blacks? So ang tanong genotype, ano daw ba yung genes na namana natin or na-inherit natin sa mainly sa mga black people? Actually, ang na-inherit nila is yung ating FY gene. Guys, yung FY gene kasi natin, okay, ito, FY. So, take note kasi, guys, yung FY gene kasi natin is considered a silent gene. Again, it is a silent gene resulting to a null phenotype. Again, tandaan natin, African American, most of them are FYA negative, B negative, meaning they inherited the silent gene FY, that's why wala silang Duffy A and Duffy B antigens. So again, what is the most common phenotype in blacks, African American? Again, that's Duffy A negative, B negative. Okay? Duffy A negative, B negative. So what phenotype, okay, can resist infection with Plasmodium vivax and Plasmodium knowlesi? So alam ko guys na natutunan nyo to sa parasitology ninyo na klase. So anong phenotype guys? Okay, yung Duffy A negative, B negative. Why? Okay, bakit daw si Duffy A negative, B negative? Sabi dito, they can resist infection from the 2 Plasmodium species, vivax and knowlesi. Why? Hello? Sino yun? Hello? Sino ka? Magpakilala ka naman kapag nagsasalita ka, girl. Christine? April. Okay. So, sabi dito, tandaan kasi natin na mga Duffy antigens natin, okay? Duffy antigens natin kasi receptor sila ng Plasmodium vivax and Plasmodium knowlesi. So, ibig sabihin, they can attach to Duffy antigens. That's why, when you are Duffy A negative, B negative, you can resist infections dito sa dalawang Plasmodium species na to. So we have here additional phenotypic markers commonly found in black donors, which can give a clue to possible presence of a silent FY allele. So ibig sabihin kapag may RO ka na antigen and you are S negative, small s negative, when you are V positive, VS negative, when you are JSA positive, and Lewis A negative, B negative, it's a clue na meron ka daw silent FY allele and meaning your phenotype is FYA negative, B negative. So let's talk about the Duffy antigens. So Duffy antigens, okay, most important in routine blood bank serology, mainly yung Duffy A and Duffy B natin. They can be identified on fetal red blood cells as early as 6 weeks gestational age. Well developed at birth at 13,000 to 14,000 Duffy A and B antigen sites on both Duffy A positive, B negative, and Duffy A negative, B positive RBCs respectively. Again, nakikita lang siya sa tissues natin, specifically sa brain, colon, endothelium, lungs, spleen, thyroid, thymus, and kidney cells. At tandaan natin, one of the most striking feature of Duffy antigens, they do not store well in saline suspension and they tend to elute, natatanggal sila, okay, or nadedetach sila from RBC stored in a medium with a very low pH or low ionic strength. And tandaan natin, ang effect ng enzyme treatment sa Duffy natin, ludum, increase or decrease? Decrease, okay? Decrease naman ang kanilang, ayan. And ayan na, basahin nyo lang yan. So guys, discuss ko na rin sa dito last time yung exhibit ng dosage, yung dosage effect natin na sinasabi, okay? So ano na kasi ulit yung dosage effect natin? So sabi dito, antibodies react more strongly to double dose homozygous than RBCs from heterozygotes. And if you still remember, diniscuss ko rin to sa inyo, and this is an example. As you can see, a white donor and a black donor. So sa white donor, naman na niya both yung FYA gene, FYA genes natin. That's why his phenotype or her phenotype is FYA positive, B negative, meaning meron siya nung FYA antigen. Next, yung black individual naman natin, meron naman na niya yung FYA gene natin and yung silent gene natin na FY. But if we're going to test it serologically, still, his phenotype is FYA positive, B negative. At tatandaan natin, kung mapapansin ninyo, the true double dose for FYA gene, which is homozygous in nature, guys, is your white donor. Kasi nga, meron siyang both your FYA genes. While, ang single dose of FYA naman is yung black donor kasi nga, isa lang yun naman na niyang FYA and the other one is the silent gene FA. So if naalala nyo, if you're going to test this using your, for example, anti-FYA na antibody, sino yung may stronger reaction? Si white individual ba or si black individual?
White.
Si white yung may stronger reaction, and then may reaction pa rin si black donor pero not as strong as the white donor kasi mas maraming Duffy A antigens yung white donor kasi nga meron siyang true double dose of Duffy A. Okay, let's proceed. Duffy antibodies. So, ano naman ang kailangan tandaan sa Duffy antibody? So, ang anti-Duffy A natin is more frequently encountered than anti-Duffy B, which is the anti-Duffy B nakikita lang doon sa mga patients with multiple antibodies. And generally, they are IgG in nature and they react at IAT or antiglobulin phase. They do not react with enzyme-treated cells. They are enhanced in a low ionic strength medium and they are associated with acute and delayed hemolytic transfusion reactions. So associated din siya sa HDN ranging mild to severe. So tingnan naman natin yung kanyang biochemistry. The Duffy antigens reside on glycoprotein of 336 amino acids that has a relative mass of 36 kilodalton and 2 glycosylation sites. Ayan. So the glycoprotein is tawag dito. The Duffy glycoprotein is predicted to traverse the cell membrane about 7 times and has predicted disulfide bridges. So kung mapapansin niyo, tandaan sa amino acid, sa amino acid, ganito to. Medyo nagulo siya. Yan. Sa amino acid number 42. Guys, sa number 42 position, okay, on the glycoprotein defines the FYA and FYB polymorphism. So sa Duffy A natin, guys, yung sa number 42, ang kanyang amino acid ay si glycine at yung sa Duffy B natin, 42nd position, yun naman si aspartic acid. Again, Duffy A, glycine, Duffy D, aspartic acid. And Duffy glycoprotein is a member of a superfamily of chemokine receptors and is now known as the Duffy antigen receptor for chemokines. So again, your Duffy glycoprotein traverses the membrane 7 times and has predicted 2 predicted disulfide bridges. Okay? Baba tayo. So, ayan. So, the Duffy glycoprotein, sorry. So, ayan. So, the Duffy glycoprotein is encoded by the FY gene found on chromosome 1, and there are 5 alleles at the Duffy locus. The most important are your Duffy A, Duffy B, and the silent allele, which is your Duffy, major allele in Black people. So, sabi dyan, Duffy A negative, B negative blocks do not express Duffy B on their RBCs, but express Duffy B on other tissues. So guys, basahin nyo na mabuti. Duffy A negative, B negative Black people, wala silang Duffy B on their RBCs, pero meron silang Duffy B sa other tissues. Tandaan natin, yung Duffy antigens natin, they can be detected sa other tissues, nabanggit ko kanina. Therefore, the presence of Duffy B in tissues presumably precludes the recognition of Duffy B as a foreign. Thus, no anti-Duffy B is made by these individuals. Okay? Intindihan. So, Duffy A negative, B negative white individuals naman do not express Duffy B on their RBCs and in other tissues and therefore can form anti-Duffy B. Alright? Napakadali. Tandaan yung dalawang yon, naka-bold. Typing for Duffy antigens has been performed on the RBCs of chimpanzees, gorillas, and Old and New World monkeys. The results suggest that Duffy 3 developed first, then Duffy B, and that Duffy A arose during human evolution. So tatandaan lang natin, sabi sa libro, na ang pinakaunang Duffy antigen daw is yung Duffy 3 natin. And we have still other Duffy antigens, your Duffy X, 3, 4, and 5. And tatandaan natin, si Duffy 6 antigen is also a receptor used by Plasmodium vivax to penetrate RBCs. So sabi dito nga, this is association, Duffy A negative, B negative individuals are Africans and Black Americans, and they are resistant to infection by Plasmodium vivax and knowlesi. So let's proceed with kid blood group system. So what about kid blood group system? So sa kid blood group system natin, na-identify daw siya sa pasyente na si Mrs. Kid. Okay? The kid system, wait lang may tanda natin kay Duffy ang Duffy natin, antigens natin, nakikita siya sa RBCs and other tissues. Okay? Yung Duffy phenotypes natin, tandaan natin yung mga yon. 4 yon. 2 yung sa white, most common. 1 yung sa Chinese population. At pinakasikat yung sa black, which is Duffy A negative, B negative natin. Huwag kakalimutan. Ano pa bang mga kailangan tandaan? Okay? Yung Duffy A and Duffy B natin, guys, magkakaiba lang sila sa amino acid position number 42. Kay Duffy A, si glycine, and kay Duffy B, si aspartic acid. Okay? So, yun. Okay, proceed tayo kay KID-009. So, sinabi ko na identify yung first antibody sa plasma or sa serum ni Mrs. Kidd, kaya tinawag na Kidd blood group system. It has a special significance to routine blood banking because of its antibodies. Why? Which it is difficult to detect. Mahirap daw i-detect ang antibodies ng KID natin. And they are notorious for causing hemolytic transfusion reaction, which is delayed type. So pag sinabi nating delayed type kasi na hemolytic transfusion natin, my dear friends, pag delayed type yung hemolytic transfusion natin, nakikita lang yung mga symptoms ng delayed type after 3 to 7 days of transfusion. While pag sinabi nating acute hemolytic transfusion reaction, in just a minute or nakikita na yung effects kung meron ba talaga kapag merong transfusion reaction. Kaya tinawag na delayed type. Tatandaan yun ha, delayed type hemolytic transfusion reaction, very significant under KID blood group system at mahirap ma-detect ang kanyang antibodies. Again, gene location, chromosome 18. So tingnan natin ang prevalence, ayan, or frequency ng phenotypes ng KID natin. So guys, bear with me and bear with the topic kasi marami tayong papag-aralan na frequencies kasi most of the time, kumukuha talaga sila sa board exam dito sa mga table na to. Kaya kinukuha ko yan sa libro. Napakalaki niyan. Ewan ko na lang kung hindi nyo aaralin. Pero kung paano siya aralin, sinabi ko naman sa inyo, paano, okay, antog dito, himay-himayin natin. First phenotype, JKA or KID A negative, B negative natin. Okay, kung mapapansin natin, pinakamarami siya sa black population, meaning predominant yung JKA antigen sa mga black individual. Next, JKA positive, B positive, both in white and Asians. JKA negative, B negative, both in, in Asians na lang yan. And ito yung tatandaan. JKA negative, B negative is rare. Pero guys, pwede natin siya makita sa 0.9% sa mga polynations. So wag kakalimutan na polynations. Ayan. Ano ba yung mga polynations natin?
Filipinos, Indonesian.
Ano? Anyway, wag nating alamin. Basta pollinations. Okay, baba na tayo. KID antigens. So, KID antigens are antithetical, KID A and KID B. They are well developed at birth, pero sa 11th week pa lang, guys, ang madedetect na dyan is si KID A or JKA. Sa 7th week naman, si JKB. They have tendency to drop to low or undetectable levels following formation. So, enzyme treatment, they are not affected. So, KID antibodies, they are not found in platelets and white blood cells as well. So KID antibodies natin, tatandaan, they are notorious. Ayan. KID antibodies have a notorious reputation in the blood bank. They demonstrate dosage, weak sila, and found in combination with other antibodies, kaya mahirap silang ma-detect. So they are IgG, but some are partly IgM. They are made in response to pregnancy or transfusion. So nagagawa lang sila kapag in response to pregnancy or transfusion. So anti-JKA is more frequently encountered than anti-JKB. So hemolytic transfusion reaction, yes, okay? Guys, hemolytic transfusion reaction, yes. Usually extravascular. Pero intravascular naman daw yung hemolytic transfusion reaction niya in severe reactions. Tatandaan nyo yan na, again, KID blood group system nagkakos ng hemolytic transfusion reaction, okay? Both extravascular and intravascular, but in severe cases, intravascular. Guys, kakaiba kasi delayed hemolytic transfusion reaction yung makikita natin sa mga taong na subjected to HTR under blood group system ng kid. So ano yung reaction niya? Tatandaan niyo dyan pasulat. Reaction is seen after 3 to 7 days 3 to 7 days transfusion of blood. Okay? And ano yung causes? Bakit tayo nagkakaroon ng delayed hemolytic transfusion? Because of secondary or anamnestic immune response. And guys, yung hemolysis natin dito sa type na to, sinasabi ko na, usually extravascular. Pag tinanong kayo guys, extravascular or intravascular? Ang sasagot pa rin, extravascular. Pero sabi sa ibang libro, intravascular siya in severe conditions or cases. Again, laboratory, okay, result, increase ang bilirubin. There is methemaalbuminemia. Urine, there is hemosideриnuria. And guys, they are direct antiglobulin test positive in days, meaning there is an antibody coating an antigen or a sensitized antigen ng antibody na kid in for 4 days, sorry. And there is also unexplained depletion of hemoglobin and hematocrit leading to anemia. HDN, yes, and rarely it is severe. So as you can see on the picture, guys, this is the kid glycoprotein and is considered a urea transporter. Okay? So, yun lang. Sige, i-discuss ko nga sa inyo saglit. Guys, yung difference ng acute at ng delayed. Again, sige, para alam nyo na. So, pag acute hemolytic transfusion reaction naman, guys, okay yung reaction niya, of course, in minutes. Minutes lang after transfusion. And then, causes, anong cause ng acute hemolytic transfusion reaction? Mostly due to incompatibility of blood. Okay? Incompatibility of blood donor to that of the recipient. And type of hemolysis, mostly guys, intravascular naman. Magkabaliktad, okay? Intravascular hemolysis naman ang type pag acute hemolytic transfusion reaction. And kung mapapansin ninyo, anong mga pwedeng mangyari kapag may acute hemolytic transfusion reaction? It will result to hypotension. Hypotension leading to disseminated intravascular coagulation and shock. So yan, apat na yan. Yung apat na to kailangang tandaan. Just minutes, incompatibility of blood, intravascular hemolysis, hypotension leading to disseminated intravascular coagulation, and shock, that's acute hemolytic transfusion reaction. Okay? Alright. So, let's discuss naman yung ayan. Teka lang ulit. May re-replyan lang ako. Let's proceed. Pasensya na guys. Sorry talaga. Pasensya na. Saan na ba tayo? Okay. So, let's discuss naman yung mga JKA negative, B negative phenotype, and the recessive allele JK. Again, yung JK natin, it is not a silent allele, but it is a recessive allele. Okay, it is not a recessive gene. Again, ang JK ang JK is a recessive allele or a gene, okay? Hindi siya a silent gene. Okay, the null phenotype is most abundant among Polynesians, yung JKA negative, B negative nga natin na sinabi. And guys, take note, nakalagay naman dyan na yung tawag dito, yung RBCs. Okay, sabi dito, there is a delayed lysis of RBCs in 2M urea 30 minutes instead of just 1 minute. Guys, this is very unique sa red blood cells ng Polynesians na may phenotype na JKA negative, B negative. And there is no clinical abnormality association. But ayun nga sabi ko sa inyo, pag tinest natin siya na with 2M urea, 30 minutes ang lysis niya instead of 1 minute. Again, normally, dapat kasi ang RBCs natin nalalyze when mixed with 2M urea, 1 minute pa lang nalalyze na yan. Pero in case of Polynesians, 30 minutes. So silent allele JK, same concept with FY. Again, tawag dito, sabi naman dito, may tinatawag tayong dominant in JK. So ano naman yung dominant JKA negative, B negative RBCs? So they absorb and elute anti-JK3, JKA, JKB, indicating that the genes are expressed but only very weak. So meron tayong mga antibody dito, si anti-JK3, tatandaan na lang natin, it is the antibody seen in patients with JKA negative, B negative. So HTR, yes. HDN, yes. So again, this is association, Enterococcus faecium, and Micrococcus were able to convert JKB negative cells to JKB positive. And Proteus mirabilis may have been the stimulus for an auto-anti-KIDB. So Lutheran. So Lutheran na tayo. Very easy lang to. Again, nakita siya sa patients, yung anti-Lutheran A found in the serum of a patient with lupus erythematosus following transfusion. So it was named after the donor's last name, Lutheran, but the sample was mislabeled as Lutheran. O, di ba? Ang cute ng history. Tandaan yan. There are 20 antigens and tatlo na yung obsolete, 22, 10, and 15. Most of the antigens are high prevalence and there are 4 sets ng antigens niya antithetical. Si Lu-A, Lu-B, Lu-6, Lu-9, Lu-8, 14, Lu-18 or AUA, Lu-19 or AUB. So antigens can be low prevalence so that only few people are exposed. So may mga para-Lutheran din tayo na antigens which are your Lutheran 11, 16, 17 and have limited evidence that they belong to the Lutheran system. So gusto ko lang paalala sa inyo, pag tinanong kayo, what is the most common phenotype sa Lutheran blood group system? Again, about 92.35% ng population natin worldwide are Lutheran A negative, B negative. So the most common antigen is your Lutheran B. So Lutheran antigens naman pag-usapan natin. What about Lutheran antigens? Lutheran A and Lutheran B are antigens produced by allelic codominant genes. So nakikita na siya sa fetal RBCs as early as 10 to 12 weeks of gestation, and they are poorly developed at birth and do not reach adult levels until age 15 years. So yung Lutheran glycoprotein naman, kung saan sila located, are widely distributed sa tissues, brain, lung, pancreas, placenta, skeletal muscle, and hepatocytes. So what are Lutheran antibodies? So again guys, kung tatanungin ninyo ako sa mga other major blood group, ito yung si Lutheran ang pinakamadalas sa tinatanong. Si anti-Lutheran A and anti-Lutheran B. So anti-Lutheran A kasi natin guys, isa siyang IgM. Okay? IgM in nature, so meaning naturally occurring and clinically insignificant. But sometimes they are IgA or IgG. At tatandaan natin, ang anti-Lutheran A, when nakapag-react siya or nag-bind siya sa Lutheran A antigen, ang itsura daw niya, ng reaction niya is loose mixed field. Tatandaan to ha, very significant or very striking feature ni anti-Lutheran A. Si anti-Lutheran B naman, okay, kabaliktaran ni anti-Lutheran A, IgG naman siya. And again, clinically significant, reactive at 37 degrees Celsius phase, and IAT. So, implicated naman siya in shortened survival of transfused cells and post-transfusion jaundice. So, HDR, yes, but mild. So, sabi ko sa inyo, they are located sa type 1 transmembrane protein. Dalawa yan, the longer LU glycoprotein and the shorter basal cell adhesion molecule or BCAM. Doon sila nakikita yung mga antigens. So genetics, sabi dyan, Lu gene is located in chromosome 19 along with age, SELE, LW, and OKA. And genes for C3, apolipoprotein C2, and myotonic dystrophy. So sabi dito, naka-bold, naka-underlined. The linkage between the Lu gene and the Se gene was the first example of autosomal linkage described in humans. So pag-usapan natin si Lutheran A negative, B negative. Guys, kung napapansin niyo, 'di ba? Mostly ng topic natin nafo-focus sa mga sa mga null phenotypes. Yung mga Lutheran A negative, B negative, JKA negative, B negative, 'di ba? FYA negative, B negative. So yun guys, huwag kayong malilito sa mga yon, okay? There are 3 genetic explanations for the Lutheran A negative, B negative phenotype. Again, kung mapapansin niyo dito, may mga genes responsible. So, the EKLF49, mode of inheritance dominant, Lu antigens here are extremely linked and other RBC antigens affected din daw or reduce ang P1, small I, INB, ANWJ, MER2, and CD44. And hindi sila gumagawa ng antibody na anti-Lu3. Again, guys, ano yung ginagawa ng JKA negative, B negative na antibody? Anti-JK3. Kung mapapansin niyo yung mga null phenotypes ngayon na pinag-uusapan natin, again, pwede silang gumawa ng antibody, tapos may number 3 lang sa taas, mostly. Okay? So, recessive type naman, kapag namana mo yung Lu, again, Lu antigens, none. Hindi, walang antigens na Lutheran sa surface ng RBC. Other RBC antigens affected, not affected. They can make anti-Lutheran 3. Okay? X-link, gene responsible, XS2. And the Lu antigens are extremely weak. Other RBC antigens not affected and cannot make anti-Lu3. So ano ba ang anti-Lu3? So sabi dito, a rare antibody that reacts with all RBCs except therefore yung Lutheran A negative, B negative. So it looks like inseparable anti-Lutheran AB and recognizes a common antigen, Lutheran 3, that is present whenever Lutheran A or Lutheran B is present. So much like the JK3 association with JKA and JKB. Okay, pareho lang yon. So sabi dito, anti-Lutheran 3 is made only by Lulu individuals or yung ng recessive type. Therefore, yung phenotype Lutheran A negative, B negative. So, RBCs from dominant and X-linked type Lutheran A negative, B negative individuals can be safely transfused to patients with anti-Lutheran 3. Alright.